Good evening, everyone. Good evening, delegates. Thank you for joining Shield Connect. And today, South Asian Federation of Obstetric and Gynecology sponsors a seminar on gestational diabetes mellitus in South Asia, Part 1. So before we start the session, let me give a brief introduction of Dr. Amrita Sarkari Jaipuriar. Ma'am is going to take this session as a coordinator and MOC. So let me give a quick introduction for ma'am. Ma'am, we welcome you on our platform.
Thank you.
Ma'am is a consultant and gynecologist and obstetrician of Jaipuriar Medical and Research Center and Garg Hospital from Gorakhpur, UP. And currently, ma'am is president of Gorakhpur Obstetric and Gynecology Society for 2020.
That is all. Thank you so much.
Thank you, ma'am.
Thank you so much. And I love those flowers which you presented. So a very warm welcome to all of you to this prestigious webinar on the subject Gestational Diabetes Mellitus in South Asia, Part 1, organized by the NCD Committee of SAFOG. And at the outset, I would like to thank Dr. Sadhana Gupta for giving me this opportunity of conducting this program. I pay my respects to all the dignitaries and office bearers of SAFOG, Dr. Rohana, Dr. Yusuf Latif Khan, Dr. Padmaraj Pant, and Dr. Sadhana Gupta. My regards to all the brilliant faculty and the speakers, experts, and the chairpersons from Sri Lanka, Nepal, Bangladesh, Pakistan, and India. And my warm welcome, a hearty welcome to all the delegates for this webinar. And dear faculty, your concerns, dedications, contributions, and efforts for improving the health of the women in this part of the world is really commendable and admirable. NCD, the non-communicable diseases account for about 60% of all deaths and 47% of all the global burden of disease, and the rates are expected to rise. Environmental factors are the major determinants. Sedentary lifestyle, extreme poverty, and inadequate health systems are major obstacles in management. The prevalence of diabetes and its adverse health effects have risen more rapidly in South Asia than in any other large region of the world. So here we are to deal with it, along with all the superstars representing their nations with their views and vision. So let's pray to the Almighty, and then let's begin the scientific session. Before starting the scientific session, I would request Dr. Ruhana Hututua for his presidential address. Over to you, sir.
Please, Dr. Ruhana, CDO.
Yeah. Thank you, Dr. Amita, for giving me this opportunity to speak a few words. So firstly, I would like to thank Dr. Padmaraj, our chair, SAFOG NCD committee, and Dr. Sadhana Gupta, the co-chair of the committee, for inviting me to this webinar today and also giving me an opportunity to speak. I know that Dr. Sadhana Gupta and Dr. Padmaraj have been very busy during the last maybe not few weeks, maybe months, organizing this webinar so well. I mean, they have been able to get experts from all our member countries. So that is a great achievement, I think. And also also real experts and stalwarts in this diabetes in the region. So I congratulate the committee for organizing this webinar. And as we all know, NCDs are rising in the South Asian region, and in that diabetes stands tall and has become a major challenge to us in this region. The type 2 diabetes has rapidly developed into a major public health problem in South Asia. People from South Asian communities are known to be up to 6 times more likely to have type 2 diabetes than other general population. Also, ethnic South Asians present with greater metabolic risk at lower levels of BMI compared to others. And type 2 diabetes appears to be to affect South Asians a decade earlier, and some complications, for example, like nephropathy, are more prevalent and progressive than in other races. So it's a major problem for us. And the prevalence of pre-diabetes is also high, and so it's its conversion to diabetes. It's alarming to see that more than 50% of those who are affected may be still remaining undiagnosed. But I think conditions are improving. Recent data shows an increasing prevalence of type 2 diabetes in urban areas as well as semi-urban areas and rural areas, involving people belonging to the middle and low socio-economic strata. So many factors have contributed to this increase. As you are all aware, these include physical inactivity, imbalanced diet, abdominal obesity, excess hepatic fat, and possibly adverse perinatal and early life nutrition. Major lifestyle changes associated with economic transition, industrialization, and urbanization, decline in nutrition quality, reduced physical activity, and increased sedentary behaviors have also contributed. So the International Diabetes Federation in 2017 estimated the prevalence of diabetes in adults in the region range from 4% in Nepal to 8.8% in India. The prevalence of overweight ranges from 16.7% in Nepal to 26% in Sri Lanka. And also the prevalence of obesity ranges from 2.9% in Nepal to 6.8% in Sri Lanka. So you can understand the gravity of the problem which we are facing. So we in South Asian countries face many barriers also in the prevention and management of diabetes because of the attitudes and the cultural differences and religious and social beliefs. Also inadequate resources, insufficient healthcare budgets, lack of medical reimbursement, and socio-economic factors. All these contribute to affect the management. So I once again congratulate Dr. Padam Raj, the chair, and Dr. Sadhana Gupta, and all the members of the SAFOG NCD committee for organizing this very useful, helpful webinar to discuss this major health problem affecting our region. So I am very happy to see Dr. Hema Divakar. As we all know, she's a pioneer in diabetes in our region. And she is not known only in our region, but globally also. She has contributed so much, including the FIGO. So we are very happy to see her because she will, from her, we will get a major.
Thank you, Rohan.
So we are also fortunate to be able to listen to leaders from the SAFOG who are experts in diabetes, Professor Ferdowsi Begum, Professor Rubina, Professor Ashwin Rana, Dr. Sham, and Professor Yusuf. And so all these are real experts and leaders in the SAFOG, and we are thankful to the organizers for being able to get them in. And I also see Dr. Hira and so many others joining in from our countries. And from Sri Lanka, I see Dr. Indu Asankar and Dr. Shamun Mali, who are experts in Sri Lanka in this field. So I am certain that with all these participation, today's discussions will be very helpful and of much value to the practicing clinicians, and will contribute very much towards our efforts to tackle the problem of diabetes in South Asian countries. Thank you very much for everything.
Thank you, sir. Thank you for those wonderful words. And Sahiti or Tulika, please, we would like to have the CV. I just missed it. I beg your pardon, sir.
Don't worry, please don't waste time on the CV.
No, sir, it's just, sir, you are our president, SAFOG, and you're the founder chairman, Nine Wells Care Mother and Baby Hospital, Colombo. and Secretary General of Asia Oceania Federation of Obs and Gynae. So I would request Dr. Padmaraj, please display his CV, please. Sahiti?
Yes, ma'am. Is
Dr.
it visible?
Padmaraj, no, I can't see that. Dr. Padmaraj is the chairperson of Non-Communicable Disease Committee of SAFOG. And we would like to hear you, Dr. Padmaraj. Please.
Thank you, Dr. Amita.
Over to you.
Thank you very much. Respected President, Secretary General of General, chairs and co-chairs of different committees, past presidents, ladies and gentlemen. Good evening and namaste. It gives me immense pleasure to welcome you all in this CME on important topic gestational diabetes, organized by Non-Communicable Disease Committee of SAFOG. As we all know and already mentioned, gestational diabetes is metabolic disease during pregnancy on rise globally and specifically in our part of world, affecting the pregnancy outcome and if timely managed, this condition and timely diagnosed, the outcome of pregnancy can be improved. But till now, there is no uniform protocols on screening of diabetes. And today our expert panel will shedding light on the same. Hope this year CME will be beneficial for all of us. I would like to thank SAFOG for providing us this opportunity, and my special thanks to Dr. Sadhana Gupta for her continuous effort to manage this CME, and thanks to all the panelists and chairs, and thanks all participants for participating today's CME. Thank you. I'll not take a long time so that we'll discuss on this aspect. Thank you very much.
Thank you, sir. I would like to welcome Dr. Sadhana Gupta, who is the co-chair of the Non-Communicable Disease Committee of SAFOG. Madam has been the vice president of the Federation of Obs and Gynae of India, and she has been a representative to SAFOG also. Over to you, ma'am. Sadhana, ma'am.
Thank you. And first of all, warm regards to SAFOG President Dr. Ruhana and all the senior people, Dr. Hema Devakar, Dr. Yusuf Latif Khan, Dr. Rubina, Dr. Ashma, and many dignitaries. And I owe a special thank to Dr. Ruhana and Dr. Padmaraj to giving me opportunity to be co-chair of this SAFOG NCD committee. And what is very important for SAFOG that we share the same sea, same mountains, Mount Everest. We are seeing Sri Lankan Sea, and we share the same problems, and we have to innovate our own solutions. So all the leadership, right from Dr. Hema, Rubina, Dr. Ruhana, we have to have our own perspective of managing our solutions. And we hope that what we are planning for having second Friday of every month for these SAFOG NCD committee webinars, that in coming webinars, we will really come out with the sharing of experience, learning from each other, and making good things for every class of the people, be it a rural, urban, educated, uneducated, because we in South Asia serve the most heterogeneous and complex population. So once again, a warm welcome to all dignitaries. I speak all thanks to all faculties. and for joining this webinar, your acceptance, your precious time, and we look forward for the wonderful discussion. And we will request Dr. Yusuf Latif Khan also to give few remarks before we go on to the scientific session as a Secretary General. Dr. Yusuf, please. Dr. Yusuf, are you? Dr. Yusuf.
Yusuf sir, are you there? Should we move on, ma'am?
Yes.
Okay, quickly moving on to the session, the first scientific session. The topic of this session is diagnostic criteria, protocols, and incidence in GDM in South Asian countries perspective. We have three speakers for this, and Dr. Indu Asanka Jayawardene from Sri Lanka, Dr. Amita Pandey from India, and Dr. Sandesh Pudal from Nepal. I would like to welcome our chairpersons for this session. Our chairpersons are Dr. Hema Divakar. Madam has been our president in the president of FOXI in the year 2013. And presently she is the medical director, Divakar Specialty Hospital, and also a senior consultant, OBGYN. She is CEO and chairman artist and Dean KCOG. You're welcome, ma'am.
Tulika, please go on flashing.
Thank you, Amita.
And our second chairperson is Professor Firdausi Begum from Bangladesh. She is from the Department of Obs and Gynae, Ibrahim Medical College, Dhaka. She is also involved in the Institute of Women and Child Health. She has been the immediate past president of SAFOG and author of many books and also an associate editor of the journals. Our third chairperson, welcome, ma'am. Welcome, Professor Firdausi, ma'am. Can we hear, ma'am?
Yes, ma'am.
Okay. Good evening, ma'am. You're welcome.
Yeah. Good evening. Good evening to everyone. I think it's a fantastic gathering. We'll be learning a lot about GDM today, and we are really happy that NCD committee is taking up. So especially Sadma and her team are doing well. Rohana and the full team going on full swing. So we are happy. And GDM is so important in the perspective of South Asia. So we'll discuss this in details today. Thank you.
Third chairperson is Dr. Sharmoon Marlin from Sri Lanka. She's an FRCOG, consultant obs and gynae at Sri Jayawardene Pura General Hospital, Sri Lanka, and fellow of Sri Lanka obs and gynae. She has many publications to her credit, and she is a council member of Sri Lanka College of Obs and Gynae and member of guidelines of all the development group. You're welcome, ma'am. Our fourth chairperson is Dr. Yusuf Latif Khan from Lahore. He is the Secretary General of SAFOG, Professor in Obs and Gynae in Rashid Latif Medical College, General Secretary of Society of Gynecological Endoscopy, Scientific Secretary of IVF Society of Pakistan. He has many publications to his credit and also a textbook of gynecology. So now the platform is for the chairperson. I would just introduce the first speaker, who is from Sri Lanka, Dr. Indu Asanka Jayawardene. She is an MRCOG, board certified specialist of Obs and Gynae, Sri Lanka. She is a senior lecturer and honorary consultant at University of Colombo and D. Soya Hospital for Women. So over to you, ma'am, Dr. Indu Asanka Jayawardene, for your presentation.
Indu is sir. Dr. Indu is.
Hi, Indu is.
Oh, sorry, sir. Sorry.
Thank you for the kind introduction, ma'am.
Sorry, sir.
Let me share my screen. Can I be allowed to share the screen, please? Thank you. Thank you. Okay, I will briefly discuss the incidence diagnostic criteria and protocols as it applies in the Sri Lankan setting, rather than the whole the most detailed discussion is actually found at a guest editorial. I will share the link with you in the Journal of SAFOG some time ago. So I'm not going to actually go into details, but I'm going to go into the process by which Sri Lanka achieved or Sri Lanka came to the place where it is in today. So I thought that would be a little bit more interesting than discussing the exact protocols, because the exact protocols and is at the moment, although it has been offered as a guideline by the Sri Lankan Ministry of Health, is still a consensus document, because it is sometimes not based on complete evidence based, but a consensus between experts. So in terms of prevalence, we all know that South Asia, especially especially our part of the continent, is certainly more affected than anywhere else in terms of diabetes and gestational diabetes. So Sri Lanka was quite pioneering a long time ago by demonstrating the fact that we simply cannot follow the Western guidelines when it comes to maternal and gestational diabetes, especially because our population seems to be quite different. We reported as far back as 2006, we reported a prevalence of 1 in 10, which was seen to be increasing. Although Sri Lanka does not have a national survey prevalence, there are adequate publications about various populations, both urban, semi-urban, and rural populations, where the incidence and prevalence is somewhere between 1 in 4 and 1 in 5, or 20 to 25%, and it certainly has increased over time. So the problem is fairly severe. It is not going to go away, and we have to deal with it. We'll have to deal with the elephant in the room. As well as in 2017, in a community setting, a group of Sri Lankan researchers demonstrated that for the people we treat as gestational diabetics and hyperglycemia in pregnancy, future risk of type 2 diabetes by 5 to 10 years, in 5 to 10 years, is as high as 50%. So there is scope for improvement on what we do. But Sri Lanka also has a certain advantages when it came to handling this problem. We had quite visionary pioneers who took this challenge quite early on, probably as early as quite early, before even the world caught up with the COIS and HAPO trials. Sri Lanka had the advantage of starting fairly early. So hyperglycemia in pregnancy as a key health problem was identified quite early in Sri Lanka. And Sri Lanka was one of the first countries to accept that universal screening, i.e. screening of all pregnancies, is the way forward, at least for our setting. And it certainly has permeated to most of the high-risk settings in the world. We accepted that optimal glycemia throughout the day, throughout the pregnancy, which means you have to aim for the optimum, as well as you have to keep making sure that optimum is reached by repeated glucose measurements, and that is the way forward in managing gestational diabetes, hyperglycemia, and pregnancy. And we were quite lucky to have introduced quite early on a multidisciplinary care effort with diabetic educator nurses, the endocrinologists and physicians, obstetric physicians, obstetricians, giving their input and combining the specialist input with the local system through the Family Health Bureau and Sri Lankan Ministry of Health sponsored the primary healthcare setting for the pregnancies. So it was a co-involvement of the clinic and the field. And Sri Lanka was one of the first countries to introduce a national guideline quite specific to gestational diabetes, hypoglycemia in pregnancy, both diabetes in pregnancy as well as gestational diabetes. So we had our strengths. On top of that, we had also a couple of other strengths, because our women were booking quite early. So we had this opportunity of screening them before 12 weeks, at least the vast majority of pregnancies in the whole country. So that's a strength that is unmatched, and high-risk women potentially could be screened for diabetes in preconception, because all eligible women, as we say, or eligible couples are registered with a community health midwife, and we know who is using contraception and who is trying to plan a pregnancy and is on folic acid. So we could actually target, if it was cost effective, if it was could be demonstrated as an useful way of managing things, we could potentially target these women for intervention pre-conception. And so it was identified as a local research priority. In developing the guidelines, the initial efforts in 2011-2012 were put forward by Sri Lanka Medical Association and Sri Lanka College of Obstetricians and Gynecologists, and the quite early guideline, the first guidelines came through and got ratified by both these institutions through a program called Nirogi Mata funding with WHO provided for us, and it was ratified by the Family Health Bureau and introduced by the Ministry of Health. And this was carried forward with a wider discussion, and then Sri Lanka College of Obstetricians and Gynecologists, with the ratification of Family Health Bureau, which is the community health arm of the Ministry of Health, ratified and produced a national guideline, which has been updated twice since its first introduction. Most recently, we have the Sri Lanka has gone a little bit more forward. I'll come and discuss a little bit more about it in reaching the consensus document with more than obstetricians and physicians getting involved. It's a wider distribution of experts and has introduced a national consensus document, and I think that's a real key way forward for managing this problem as a community and at national level. Now, Journal of SAFOG has been quite active with helping out the dissemination of knowledge on this. I suggest for anybody who is interested in looking up what's the situation in terms of guidelines and management of hyperglycemia in pregnancy, to go here where the guest editorial of Journal of SAFOG invited the Sri Lankan Ministry of Health to discuss its guideline, and a quite detailed discussion is there in this editorial, which is quite informative in terms of our efforts in Sri Lanka. Now, this is the document that I was talking about, and a national consensus document. Why do we need a consensus document? Because for some issues, we know there are issues, and we have gut feelings that there are issues, and they are rational, but sometimes we don't have the exact detailed, the exact evidence that we need in terms of randomized clinical trials or uncollected evidence. We really can't wait to manage our women until our researchers go and find that evidence. So a consensus document therefore addresses these deficiencies, and a wider participation is needed to discuss about the cutoffs, laboratory cutoffs. So chemical pathologists, the College of Chemical Pathologists of Sri Lanka has been involved, and how to deal with the nutrition, the self-glucose monitoring, the medical nutrition therapy of these women. So the medical nutrition, College of Sri Lanka Medical Nutrition, or the Medical Nutrition Association got involved, the physicians got involved, and the endocrinologist and the College of Obs and Gynae. So a consensus, national consensus document ratified by Ministry of Health is quite a leap forward in managing it as a country problem. So in this document, they have come up with addressing this problem in terms of screening of pre-gestational diabetes in this country setting, and how should we manage preconception care if the woman is diagnosed as diabetic, and how to screen and diagnose of hypoglycemia pregnancy and gestational diabetes, management of hypoglycemia in pregnancy, the pharmacological treatment, when to introduce insulin, metformin, and what can be used and what can't be used. How is the detailed antenatal care provision in terms of collaborating with the field, with the community care, so that you have optimum shared care, intrapartum and postpartum management, the care of the newborn and the child, and how to deal with women who has had a intrauterine fetal death. So it's a fairly comprehensive document, and it involves a lot of detailed evidence-based discussions and evidence-based recommendations. Where we don't have evidence, people have decided to go with a consensus, because it is important in this topic that we all speak the same language. If a woman is told that she's diabetic in one clinic and she goes to someplace else and she is told that she's not, then the system, the trust in the whole system collapses. And so it's important to have one message. And as the evidence piles up, we can obviously amend and discuss our consensus, because it is a consensus. So in terms of, I'll just briefly go through what this document says, provided I have time. Please remind somebody. If I run out of time, I don't want to run out of time. I would like to leave some time for the comments as well. So in terms of screening for pre-gestational diabetes, the guidelines suggest that it should be universal, and the screening should be at the booking visit. Remember that this booking visit for 90% of Sri Lankan women is somewhere around 8 weeks or less. Therefore, we can certainly use fasting blood sugar, a PPBS, or an HbA1c, as suggested by this document, to screen for pre-gestational diabetes. If they have diabetic cutoffs, then they are labeled as pre-gestational diabetes and managed as diabetics. If impaired glucose tolerance, if it comes with impaired glucose tolerance cutoffs, an early glucose tolerance test will determine a diagnosis for gestational diabetes, or a pre-gestational diabetes, if it is done before 12 weeks. So that's the consensus. I agree that we can debate all these, but as long as we have come to a consensus and we go with the same criteria, I think that's less confusing to both practitioners and women than trying to follow individual unit-based consensus and unit-based guidelines, which can be quite confusing and difficult to maintain. And in pre-conception, as I said, Sri Lanka has this unique strength of having women or couples, married couples getting registered with their community midwife. They are provided with, if they are planning a pregnancy, they are provided with free folic acid at the community level and advice and guidance from the midwife. If they are not planning a pregnancy, they are offered contraception by the midwife and through the medical officer of health area medical of health clinics. So they all get registered. So there's an eligible couples register, and there's a community midwife, and it's all it's fairly cheap to equip them with a glucometer to do a fasting blood sugar to screen women who are planning a pregnancy. So that's where the consensus is at. We will need, certainly before implementing it island-wide or country-wide, I think we should do at least some cost-effectiveness studies. But the consensus is that we should offer screening because our risk of undiagnosed diabetes in the reproductive health age women is fairly high in Sri Lanka. That is a published fact. If we diagnose preconception, then optimizing women before conception can be done. And that the consensus is quite detailed, and we all know how to do it, including retinopathy, nephropathy screening, optimizing HbA1c, etc., etc. And how to diagnose gestational diabetes is the next topic. In women who have a negative test at booking, and those who have a negative screening at booking, a glucose test, 75 gram OGTT, is recommended and carried out between 20 to 28 weeks to diagnose gestational diabetes. So hypoglycemia in pregnancy is either pre-gestational or diabetes, or already existing diabetes, or gestational diabetes mellitus. And the suggested cutoffs are fasting 100, first hour 180, and second hour 140. Any one qualifies. I agree that, again, these cutoffs can be debated with the evidence, but again, having a consensus on one cutoff makes our lives much easier. So management of hyperglycemia in pregnancy. So we advocate self blood glucose monitoring wherever she can. The woman herself monitoring her blood glucose with a glucometer at home is preferred to they go into the lab. And we give the therapeutic targets, and initial management is medical nutrition therapy and exercise. So a multidisciplinary team approach is encouraged at both the clinic and the community level. Then there is advice about pharmacological treatment, insulin, and metformin. I don't really need to go into details because we are going to discuss details. Our experts are going to discuss details in the next coming sessions. We recommend a combined antenatal and diabetic clinic, preferably with the hospital physician and the obstetrician combining to a single clinic. Recommended antenatal visits include 16, 20, 24, 28, 32, 34, and 36 weeks. And then at 36 weeks, the obstetrician decides the time and mode of delivery and the needed care until and the follow-up until she is delivered. Intrapartum, as we all know, intrapartum is a problematic if you're on insulin and complicated diabetic. So some details are there. The physicians and endocrinologists advising us, and the timing and mode of delivery. The important thing now is that we have a consensus that allows going up to 40 weeks completion of dates for selected patients who are uncomplicated gestational diabetics, especially diabetics who are well controlled with medical nutrition therapy. And this is a huge improvement because the problems with induction of labor at 37 weeks with unfavorable cervix, and you ending up with cesarean sections, which are probably not necessary. And there's postpartum care of the and the care of the child and the newborn, and there are detailed discussions about what to do in the day after delivery and what to do before discharge, and how to manage. And it's important to offer these women who are actually gestational diabetics a screen a screen at 6 to 12 weeks to make sure that they're actually gestational diabetics who have gone off hyperglycemia, or if they're still carrying hyperglycemia, then they are probably diabetic. So a screen at 6 to 12 weeks, and this is implemented by their community midwife, because she's been informed that they need this test, and they can come and get it done at the medical office of health clinics free of charge. Breastfeeding and newborn care and fetal loss. So these are the key issues that one needs to come into a consensus. And when coming into a consensus, like I discussed, it's important that a larger audience than simple obstetricians and gynecologists and some physicians coming into detailed discussion. It needs a larger audience and a wider acceptance. And if we come to consensus, it's easier, because then we give the same targets, same message to every clinician who is managing this difficult problem. I agree that we don't have the necessary data, necessary evidence to completely give an evidence-based guideline on this. And so it's up to each country, each one of us to initiate this sort of consensus, so that this confusing array of different managements can be brought and can be understood by our juniors and people who want to manage these women better. Thank you so much. If there's any questions, I'll be happy to answer them. Thank you so much.
Thank you, sir. And now I'll request our chairperson, Dr. Hema Divakar ma'am, to give her expert comments.
Thank you, Amrita. Thanks, Sadhna, and all the esteemed members here. It was indeed a very exhaustive presentation from start to finish, A to Z, of the problems that we are dealing with in our own countries. My comments, if you would not mind, would be reserved after all the three speakers speak, because when Sadhna mentioned that compared to the rest of the world, the SAFOG regions have some very special contextual issues to deal with, but within the SAFOG regions as well, there are constraints in different countries, inclusive of Sri Lanka, Nepal, Bangladesh, India, and the others. So when we have an overview, a 360 degrees with the three speakers, I think all the four of us who are the so-called experts on this panel will be free to make our comments, and that would be probably more appropriate. Yes, Sadhna?
Yes.
Okay, ma'am. Okay, ma'am.
Thank you.
So moving on to the second talk, and it is by Dr. Amita Pandey from India. She is Professor, Department of Obs and Gynae, KGMU, Lucknow, UP, India. And she is the winner of several awards, more than 100 publications to her credit. And she is involved in various research projects. She is a visiting professor to New York also. And she is an expert in development of several maternal health guidelines for the government of India. So over to you, ma'am, for your presentation.
Very good afternoon to all of you. It is indeed an honor and privilege for me to be a part of such an important and such an esteemed platform where we are discussing such an important issue like gestational diabetes mellitus. My heartfelt gratitude to Dr. Sadhna Gupta and the other members of the organizing team for giving me this wonderful opportunity to interact with such esteemed stalwarts in the field of gestational diabetes. So here I would be presenting the Indian perspective as far as the diagnostic criteria, protocols, and the incidence of gestational diabetes are concerned. Now, I would also like to begin with a very brief history. And I would like to begin around 2 decades back when the world was actually warming up to the global pandemic of diabetes, when people were realizing that Asians particularly are having a very high prevalence of diabetes, and various studies reported how Southeast Asia was having a very high prevalence of gestational diabetes, mellitus too, and there were several country-specific presentations and data was there where various countries were presenting their incidences of gestational diabetes, and they were all debating as to which criteria for diagnosis to be used, whether it was the WHO criteria or the NDDG criteria or the Carpenter-Couston test or the IAD-PSG criteria or so many other criteria. Almost at the same time, way back at the beginning of this century, some stalwarts, some doyens, some researchers realized that gestational diabetes mellitus is going to be a big problem for India also. And thereby started a lot of focused work and lot of interest in this field. And subsequently, right from the year 2000, we started having some very important papers on gestational diabetes in India, following some very good research which was done in this field. So we had good papers right from 2004, 2006, 2008, 2011. These are all landmark studies on gestational diabetes in India. And the researchers finally realized that there are very unique challenges in the diagnosis and management of GDM in a country like India. And I'm sure most of the people from other Southeast Asian countries would also identify and would also connect with us as far as these challenges are concerned. The first and the foremost challenge that the doyens, the researchers faced was which test to use for screening and testing for GDM. Should they use 2 different tests, one for screening and one for testing, as was being used world over at that time? Or should they go in for a single test? The situation in India was very different as compared to the West and as compared to other Southeast Asian countries also. The most important problem with our country was that of the size and that of the numbers. It's a huge country with a large population. So testing the entire population of pregnant women, the entire cohort of pregnant women was a Herculean task. So one had, moreover, the health facilities were at quite a different distance. Moreover, the transit time the patients took to reach the health facility was also more. Most of the population was basically living in rural India, and expecting them to reach the health facility for a 2-step test or as and when demanded or multiple number of times was very difficult. So the researchers started thinking as to, can there be any modification in the tests that we use for screening and testing for gestational diabetes? Then the second challenge was whom to test, when to test, how often to test. And once gestational diabetes was diagnosed, how to manage during pregnancy and what to do about postpartum follow-up. So this was followed by more studies on gestational diabetes, more landmark studies where special tests were being devised, special single-step tests which could be taken by women at one point of time. And finally, a DIPSI panel was made, that is the Diabetes in Pregnancy Study Group of India. And a large number of the members of this panel are a part of this group also. We have our respected Hema Divakar ma'am, who was one of the pioneers and an important spokesperson of this DIPSI panel, who pushed the fact that diabetes in pregnancy in India is actually very, very different. It has its own challenges. So the solutions also have to be very, very unique. And thereafter, the Ministry of Health and Family Welfare decided to have a large group meeting of these experts who were obstetricians and gynecologists, endocrinologists, physicians, community medicine specialists, and they came up with the National Guidelines for Diagnosis and Management of Gestational Diabetes in the year 2014, which was further modified in the year 2018. And these guidelines, the highlights of these guidelines was the use of a single-step DIPSI test for the diagnosis of gestational diabetes. This unique DIPSI test that is being used in India is actually the baby of this DIPSI group that was formed for the focus study of gestational diabetes in India per se. And this is a very special test, which is a single test for both screening and testing for diabetes, which is done in the non-fasting state in all pregnant women with gestational diabetes. The second important highlight of this guideline was point-of-care testing using plasma-calibrated glucometer. The third highlight was promoting self-monitoring of blood glucose by the women. And finally, including metformin after 20 weeks of gestation in the management of this gestational diabetes, if it is not controlled by lifestyle modifications and diet control. Following this guideline this landmark guideline by the Ministry of Health and Family Welfare, all pregnant women were universally tested twice during pregnancy. The first test was They were subjected to the first test as early as possible in pregnancy at the first antenatal contact. And the second test was administered during 24 to 28 weeks if the first test was negative. And believe me, even implementing this was a Herculean effort. And lot many people who are there on this esteemed platform would remember and would acknowledge how difficult it was and how they went about training people from one step to the next step to make them, to increase awareness about this test. The feasibility of this test was drilled into their minds, and finally it was implemented. The test, as I said, is a single step 75-gram 2-hour blood sugar test, which is done in pregnant women irrespective of their fasting status. The pregnant women are administered 75-gram glucose, and blood sugar is assessed using a plasma calibrated glucometer at the point of testing, and all cutoffs more than or equal to 140 milligram per DL is taken as cutoff for diagnosis of gestational diabetes. Now, this wonderful test, though was started in the year 2006 and was first published in the year 2009, is a wonderful test. It's just a walk-in, simple to perform test, very economical, does not need our women to be fasting, which is very, very important for us, because our women have to travel long distances to reach the health facility for the test, and it is not possible for a pregnant woman to reach the health facility in a fasting state. And this test was finally compared to the various elaborate tests of glucose intolerance in pregnancy, and it fared fairly well. So this test had a very patient-friendly approach, causing least disturbance in the pregnant woman's routine activities. And it was especially very, very useful in public health settings. And just to quote the researchers, who in turn quoted Albert Einstein, they started this test saying that the most complicated problems in the universe have a simple solution. And I think I would vouch for it that the DIPSI test is indeed a very simple solution to a mammoth problem like gestational diabetes. Then the guidelines came up with the nitty-gritties of the management of gestational diabetes by medical nutrition therapy and exercise, what to advocate in medical nutrition, what to advocate about exercise, what target blood sugars to be maintained during pregnancy, what to do if blood sugars are not controlled on medical nutrition therapy and exercise. The two alternatives, details about this, metformin and insulin, are worded in this guideline. And finally, they also have, this guideline also puts down the details of antenatal care in the gestational diabetes, the recommendations regarding ultrasound, the use of antenatal steroids for fetal lung maturity, the intrapartum management, the mode of delivery, when to deliver, how to deliver, what precautions to take during labor, the neonatal management, when to label hypoglycemia in the neonate, in a neonate that has normal birth weight and a neonate with fetal growth restriction, and what to do about post-delivery follow-up. As Dr. Jayavardhane has said, even Indian guidelines emphasize on 75 gram OGTT at or after 6 weeks. And a lot of emphasis was paid on syncing women with, registering women with gestational diabetes with the NCD clinic that are running all over the India in the various government health facilities. Preconception counseling details were also put down in this guideline. Now, after talking about this guideline, I would lastly come to the incidence of gestational diabetes in India. And as I have just discussed, India being a vast country and a country where the numbers are large, many studies have been done from North India, South India, East India, West India, where the incidence has been variably reported from 4% to 18.1% in different states, different areas, rural areas, urban areas. If I talk about our center, which is an important teaching institute in North India, if I am just quoting figures from the COVID times, here we screened 22,300 pregnant women, out of whom 2,373 women, that is 10.64% pregnant women, were found to have gestational diabetes. So to conclude, I would say that as the numbers are increasing, we all know that diabetes is going to be a mammoth problem, and so is gestational diabetes. And as our figures, as our prevalence, as our incidence is increasing with each passing day, the road ahead is not very easy. The times are difficult, so we have to join hands to tackle this GDM tsunami if we really want to make a difference. Thank you all for your very patient hearing. And if there are any questions, I would be very happy to take them.
Thank you, ma'am. We would be taking the questions in the end. So as suggested by Hema ma'am, we will quickly move on to the third talk by Dr. Sandesh Poodle from Nepal. He is a Chief Consultant Obs-Gynae at Paropkar Maternity and Women's Hospital, Thapathali, an Associate Professor, National Academy of Medical Sciences. He is also presently the treasurer of Nepal Society of Obs-Gynae. He is a trainer, especially in the abortion cases, and also he is involved in research and many pilot projects. So over to you, Dr. Sandesh, for your views in the incidence of diabetes in Nepal.
Thank you, ma'am. I would like to share my screen. Is it very, it's visible, I guess.
Yes, so beautiful.
Yes.
Okay. First of all, thank you very much for giving me this opportunity. I'll be presenting Nepal's perspective when we talk about the incidents, the diagnostic criteria, and the protocol, whatever we have. I'd like to thank NCD committee for organizing such an important CME and webinar on such an important topic. This is going to be I think this is going to be a landmark where we can decide on what to do, especially for a country like us who are still on a process of making diagnostic criteria and all the protocols. So without any delay, regarding the incidents, we don't have a SS data. We have a national demographic health survey, which does not include diabetes. SS diabetes itself, diabetes also, it hasn't included. It has included hypertension, increased blood pressure, but they have not still include diabetes. So when it has not been done, when the diabetes has not included, we are not expecting much on gestational diabetes. So we all know that Nepal is a small country having various geographical variations and different ethnicity. So when we talk about the geographical variations, we have mountains, hills, and plains, all have a different kind of ethnicity and population. So obviously the data what we have till now are very inconsistent. There are few data from different hospital and medical colleges. They they have reported the incidence varying from 0.6 to 8.29, and they have also taken different criteria to diagnose the case. And to our surprise, there was a study done by an endocrinologist in the endocrine center who have reported it was basically a prospective study. They have reported an incidence of 27%. And these are all which the incidents I talked about, it was from an urban area. So there was one study taking rural community, which showed the prevalence of 2.5%. Okay, I can't. Okay, just to cite some of the few studies what we have. A study was done in Nepal Medical College using a WHO criteria. It was where the 600 pregnant women were enrolled. It showed 4.5% GDM, and especially it was more prevalent on age more than 35 years. And the same author from the same medical college had done a comparative study regarding the criteria, especially the WHO 2018 criteria and the DIPSI criteria. And she found that both of the criteria, the DIPSI criteria and with the WHO criteria, the incidence came out to be same, as ma'am had already talked about the DIPSI. So they, though the sample size were very small, they took 425 pregnant women. And the study which I mentioned was especially in the hilly areas. So when you talk about the plain, especially in the Tarai area where we have a border with India, there was a study done by the National Medical College in Birganj. They reported the incidence as 8.29%, and they use GCT two-step procedure. They took GCT followed by OGTT with 100 gram glucose, though the sample size was quite small. And similar, there was this is a rural study done in a rural area. It was a hospital-based cross-sectional study in 3 different districts, which included all the 3 regions of Nepal. This was especially in the rural area, mountainous area, hilly, and the Tarai area. This was the study done in 2010, and they had 564 pregnant women. They did 75 gram OGTT. They took both WHO as well as the IAPDST criteria, and they compared. And with that, the WHO criteria, it came around 2.5%, and with IADPSC criteria, it was 6.6%. the study which I quoted a few minutes before was in the private hospital where they use ADA criteria at 24 to 28 weeks. They had this very small size and the most of the women they found GDM were obese. So we all know we don't have a particular reported. We only had a sporadic reported incidents. We don't have a national guideline. So due to this, we still don't have a particular consistency on which diagnostic criteria should we take. Some are taking WHO, some are taking DIPSI, some are taking ADA. We still don't have a consistency on which whether we do one step or two step. Every hospital has its own guideline. The hospital where I work, it's a Parapaka maternity and women's hospital. It delivers more than 22,000 deliveries a year. We are at present doing a single step 2013 WHO criteria with 75 gram positivity, and we do a universal screening. Regarding the protocols, we still, as I told you, we still don't know any standard protocol. Every hospital has, not all the hospitals, but most of the bigger hospitals, they have their own criteria. But still, they are, most of the time, they are not consistently followed. Luckily, what we, the Curator Service Division of Ministry of Health and Population, with the help of NESOG, has recently taken an initiative in making a standard treatment protocol for different obstetric conditions, and that includes gestational diabetes mellitus too. And I'm very happy to share that I am one of the 4 members who are taking charge of making this standard treatment protocol. And I think, I'm sure with this webinar and all the discussions and the conclusions coming from the discussions will help us to guide a path and help us to guide as per our need, guide on making diagnostic criteria and treatment protocol as per our need. So I think, I'm sure next time when we meet, we can have our own share. We can share our own findings and our own protocols. So again, I'd like to thank everyone for hearing me out, and I hope to take as many as informations and help from you so that we can Nepal can have a good status on our incidents and our treatment protocols and the diagnostic criteria. Thank you, everyone.
Thank you, sir, for the brief presentation. And with due respects to our chairperson, I would like all the chairpersons, Dr. Hima Divakar, Professor Firdausi Begum, Dr. Sharmoon, and Dr. Yusuf Latif Khan to give their views. Over to you, ma'am.
Thank you so much. As promised, I just wanted to bring out the fact that it's been a decade since we are debating and rediscussing, and some of our countries, just like Amita said, in India, yes, we have a single step protocol. Yes, the OBGYNs have been sensitized. Yes, the FIGO has come to the rescue, saying that in low middle income countries, this is approved by the professional organization, and you all please go ahead. And professional organization voice has been listened to by our government, and then we have pushed it into the recommendation. Having said all that, though this is the simple test, though we know it is not the ideal, though we know we can't reach our women in the fasting state, the scorecard, as we call, 100 out of 100 pregnant women should be tested by this very simple test at 12 weeks. And if that's negative, then at 20 or 22 weeks. If we reflect on what's really happening, the ground realities in our country, even as I speak today, the scorecard does not indicate anything more than 28%. That means in this complex country, 28 out of 100 women are actually being tested, and the rest of it, inclusive of the private centers, have some confusion, some conflicts, something or the other, which is making them do the test sometimes, not do the test uniformly as a universal testing, etc. And we really have to sing the same song, come together strongly with the same voice, and we urge the rest of the SAFOG countries. We are so proud that the speakers today were a part of the protocol recommendation formation and influencing the government, etc. So also in the other countries, we would want you as a professional organizations on behalf of SAFOG and your own local organizations, make it a well understandable, practical, feasible, pragmatic, doable test in your own countries. We will move slowly towards the ideal test, because we have now the idea of the digital connect, and we have non-invasive equipment, which is just like a wristband, which the patient can wear, or semi-skilled workers going home to home can do the tests in a very simple way. We will be able to go to the ideal state of doing the fasting and doing any number of tests on any number of women, but that is way ahead. But what we can do today, let us begin from there, is my very strong and simple plea. Let's not look towards yesterday, because we can't have a better tomorrow if we do that. Let's do whatever possible today. Having said that, the topic was about incidence, which is really the true incidences are known in our own countries, because if everybody is tested, more and more number of cases will come to light. And as we all agree that it's a silent killer, we have no clue, no symptoms, no nothing to know whether this patient has hyperglycemia as against the other patient. Then next is the diagnostic criteria. You have seen all the presentations speaking a little bit differently, though the aim for every country is not to miss a single case of hyperglycemia, because it has huge implications, both in the short term and the long term. The third point in the title was protocols. Yes, once we take the first step, Rubina is here, and the Pehla Kadam of the Pakistan, which was the initiative that they took for just take the first step at least, just start testing everybody, and then many more things will come to light. So the step of the SAFOG chairs getting us together today is in itself a very big Pehla Kadam, because the more we talk, the more we recognize that we can do more, is so crucial for streamlining our own house and NCDs in general, and hyperglycemia in particular has far-reaching complications for the generation next. So let's do our bit in a responsible way. Is once again on this platform, as how I do in most other platforms, I would like to emphasize that please, each one of us, take the responsibility of doing our best bit for each and every girl and women in every part of our own countries, and at FIGO raise the voice at the global level, because we very proudly say that FIGO is the global voice for women's health, and a large part of South Asian countries should be heard at the global level as well. With that, I would welcome my beloved chairpersons who are on the same panel, Yusuf Latif Khan and Firdausi Begum Appa and Chair Moon, to place their views as well. Thank you.
Thank you.
Thank you, ma'am.
I think it's going on well. I must be congratulating the whole team who has organized this. Good afternoon to everyone. You know that we are talking of this GDM part of NCD, which is so important as it is, because it's a huge problem. Incidence is quite high, the complications rate is high, and the management guidelines, then the screening process itself. You know, if I talk about my country, and it is almost everywhere in our region, that one antenatal care is being given to almost 60 to 70% of our women in pregnancy. Now, what about this 30 to 40% women? They are not in touch of any health services. Look at the wide scenario in our countries. And again, only 30 to 40% are getting required 4 to maybe 8 visits. And so we question about the quality of antenatal care and the screening everywhere. So this is fundamental thing. We have not only to decide about how to screen, but when to screen, how to bring everyone under screening coverage and proper management. That is the question. Similarly, as we know, the stillbirth is a huge problem in our part of the countries. I think we're keeping our eyes closed somehow. And we know that this hyperglycemia is one of the major significant cause of stillbirth again, preterm birth, stillbirth. So it's not only an issue of GDM itself. It's like cancer approaching in different directions. So I think we must be coming together, make guidelines strong, and it's not only the clinical ones. We think about the public health perspective as well. So with this, I welcome you again and congratulate you again for this. But the end story is we need to work together and with more vigor and concentration. Thank you so much.
Thank you, ma'am. So over to Sharmoon, ma'am.
Yes, thank you very much. I would like to thank all the presenters for the very insightful presentations on different countries' perspective. In terms of Sri Lanka, I think as Dr. Indu Asanka said, in terms of screening, I think we are doing pretty well because we are managing to get most of our pregnant women screened at a very early gestation, as he had mentioned. Most of our women book in by around 8 weeks. So we are managing to get the screening test done. However, I still think that in terms of screening in Sri Lanka, we still have a lot of, we don't have consensus regarding which test to really do. There's a significant variation between our different settings in terms of what tests they do. And there is still a sort of variation with regard to cutoffs, with some centers following the HAPO guidelines, some people following the SLCOG Sri Lankan College guidelines. So I think we need to work on also establishing some uniformity within Sri Lanka in terms of which guidelines we are going to follow and what screening tests we are going to do at the outset. The main dissimilarities are mainly in the first trimester screening and booking. Most of us, of course, are doing the 24 to 28 weeks OGTT, but first trimester screening, there's still a lot of confusion. I think that's something we also need to address. And once again, Dr. Asanka in our setting told that once in terms of antenatal care and monitoring, we seem to have quite a bit of uniformity. However, again, when it comes to planning, delivery time, etc., there is still quite a bit of variation in Sri Lanka in terms of practices among the different centers. So I think it would be useful to have this discussion regarding what is the timing of delivery, because some centers are delivering as early as 37, 38 weeks, even among those who are well controlled with just medical nutrition therapy and exercise. So I think even that needs a bit of addressing in terms of generating some consensus. So it would be useful to put it out to the rest of the people here as well about your thoughts. We did run through quite a bit, especially we didn't go through in detail about the rest of the pregnancy care and timing of delivery. We did a lot about screening and in the first trimester, etc. But I think through these discussions, we probably need to develop some consensus for us all. So thank you very much. Once again, I'd like to put it out to all of you to have this interactive discussion on these areas that I addressed.
Okay. Thank you, ma'am. Over to Khan, sir.
All right. Good evening and good afternoon to everybody. And first of all, I would like to congratulate Dr. Sadhna, Dr. Padam for again making us meet our own SAFOG memory after a break of about a couple of months. And I'm sure the three speakers, I think they excellently spoke about this diabetes, about their own country. And as sitting here, you can well imagine the difference between the Sri Lanka and Nepal, which was clearly that in Sri Lanka, they have actually not reinvented the meal, but actually gone there, which every country, especially in Pakistan and Bangladesh, we dream of, that every patient has to be screened or universal screening for everybody. And as they say, 80% of the population is screened by 8 weeks, which is, I think, a great success. And probably for them would be the next step would be probably more working on the pre-pregnancy part, so they can even screen better. Because as you know that if this disease is kind of controlled as early as possible or even before conception, the outcome and the variation, the morbidity and mortality, they kind of vary a lot. So from sky high, we can hit the lowest down values for doing that. And it's, yes, you know, 1,000-mile journey does start with a single step. And all of us sitting here talking about diabetes and we don't have to kind of reinvent the wheel, but we have to adopt it according to our own social culture or requirement. And the most important part is the economic effect it has on that. I'm sure that the India, the DIPSI test is not the best one, but I would like it should be done universally in everyone before we can achieve to going to single test or double test or whatever test we devised it till then. It is a good tool. At least it manages most of the things, or maybe about, if not 100%, maybe we can kind of cut it down to 80, 85%. If we can even target those 85% population, the mortality rate or the SDGs which we aim to target at can be achieved sooner or later. But it was indeed a pleasure to have this. And I would say that the only thing which we're kind of missing, one was, of course, the timing of the delivery. I think timing of the delivery, as my previous expert also mentioned, is not actually just the time you just clock it out. It is going to have to have 37 weeks or 38 or 40. It has to be managed according to the patients as well. You need to kind of review that. If the patient is coming from your own city or from a close by area, that's a totally different story. But if the patient has come from a far off land, from a periphery, then you just can't just tell them, okay, you just stay in the city for next 3 weeks or so weeks, and then we'll decide later on. So it has to be modified according to the needs and whatever, you know, that's my perspective. And this we try to practice that in our time. You can't have a across the board. Yes, you can have the guidelines, but you can't put it on a jigsaw puzzle on across the board for everyone for that. And hopefully if we kind of stick together and Dr. Sadhna and her team can keep on pushing us this, hopefully this will kind of transmit into our patients and for their better services, better outcomes. And we will be more than happier to do that. So thank you again for everyone. And it was indeed a pleasure to be here. Thank you, everyone.
Thank you, sir. Thank you, sir, for the wonderful comments. And thank you all the respected chairpersons for sparing your precious time and your remarkable comments. Thanks to the learned speakers for your deliberations. And now we quickly move on to the second session. The topic is maternal nutritional therapy and lifestyle modifications in GDM, complexity of the simplicity. The speaker for this session is none other than Dr. Rubina Suhail from Pakistan. Madam is the consultant OBGYN, Hamid Latif Hospital, Lahore, and she's a champion of sexual and reproductive health and rights and pioneer of kangaroo mother care in Pakistan. She has been the chair of FIGO Committee of Women Facing Crisis and also a past president of SAFOG. I would respectfully invite the chairpersons for this session. Our chairperson for this session are Dr. Hira Tuladhar from Nepal. She is professor and head of the Department of OBGYN at KIST Medical College Teaching Hospital, Lalitpur, Nepal. And she has been the immediate past president of Nepal Society of Obs and Gynae and also a past joint secretary of SAFOG. And she is a trainer and achiever and achieved many awards and has many publications to her credit. Our second chairperson is Dr. T.V. Chitra from India. She is Professor and Unit Head, Chief of Obs and Gynae, PSG Institute of Medical Sciences, Coimbatore, Tamil Nadu. And she is affiliated and has been president of COVI OBGYN Society and has been the scientific committee member of UVA FOXY 2019. She has interests in urogynecology and high-risk pregnancy, and that is what brings her here, and has been honored, has many awards to her credit and many publications. So over to Dr. Robina Sohail for her presentation.
Thank you very much. And I would like to acknowledge a couple of people, Dr. Rohana Hatutova, Dr. Yusuf Latif, Chair of the committee, Dr. Padam Rajpant, Dr. Sadhna Gupta, Dr. Firdausi Begum, Hema Divakar, my friend, and the chairs of this session, Hira Taludar and Dr. Chitra, and my dear friend who has been speaking nonstop now and introducing everybody, Dr. Amrita. So a very good evening. All of you, and it's been a real pleasure to be here and talking amongst you. When Hema was talking and followed by Yusuf, I was just thinking that maybe this is time to do a Google form study to see what are the pattern of the various gynecologists of the region in dealing with the gestational diabetes. Are we screening? Are we not? And then develop a one-page infographic for all the gynecologists, which we put up in all the conferences, be that of family physician, be that of specialists, and make sure that we try to implement them not only in the basic health facilities, but also in the tertiary care hospitals. So maybe Hema and I can later on sit down and talk about it, but it was an exciting idea to begin with. Diabetes is a disease, I think, whether it is gestational diabetes or it's otherwise diabetes. I think diabetes is a disease in which there are controversies, strong opinions, and different opinions of different people. So everybody is trying to do it somehow in a different fashion, because we feel that having such a big load of patients with diabetes coming to us, that we can do what we want to, and maybe a bit differently than the others who have done it before us. So that is why it becomes controversial, and that is why it is difficult to control. My component of the management of diabetes is basically to do with nutritional therapy. And we have to realize that diabetes basically is increasing the short-term and long-term complications, not only for the pregnant mother, but also for the in utero fetus and for the offspring in the future. So that is why we are worried and we are bothered about the control of diabetes. We want to achieve normoglycemia, and for achievement of normoglycemia, we have to make sure that the weight gain is adequate. We have to make sure that the fetal growth is adequate. So we don't want a macrosomic baby, but on the other hand, we also don't want a baby who's barely growing and whose placental insufficiency is happening. And we don't want the starvation ketosis to happen. So these are our objectives when we are trying to manage a patient who has got gestational diabetes. Lifestyle component, I later on gave up because there are a lot of things that I want to talk about lifestyle, but an active lifestyle definitely helps manage gestational diabetes. And I would share with you one of my patients who came to me and in whom we tried to control the gestational diabetes by lifestyle modification, then by diet control, then by oral hypoglycemics, and finally we went on to reach insulin. And then the patient vanished for a month. She came back to me after a month, and she was not taking insulin. She had stopped the metformin, and she had controlled her blood sugar only on diet and lifestyle modification. Such is the importance of lifestyle modification for us and the nutritional therapy that we keep on talking about. So this presentation in that sense becomes significantly important, because the medical nutrition therapy is actually the backbone for the management of gestational diabetes. And again, as I said, that these things can also be controversial. Now, the important thing to realize is that gestational diabetes can actually be prevented. And over here, I have put in 2 or 3 slides because I wanted to talk about the fact that the gestational weight gain is a major risk factor for development of gestational diabetes, and so is the pre-pregnancy BMI. So if women are going to gain more weight during the first trimester of pregnancy, there's an increased, and there is evidence for this, that there's an 80% increase probability of them developing gestational diabetes if they are developing excessive weight gain in the first trimester of pregnancy. And this is something with which, if we can counsel our patients, we can in many of them actually prevent diabetes from happening. Now, gestational diabetes prevention is actually a gameplay, and control is a gameplay between the weight gain and the BMI and the calories. So the Institute of Medicine guidelines are actually recommending what is the appropriate amount of weight gain for women with a certain BMI, and we are going to talk about that. And also that the research has shown that there is no definite upper limit on the number of calories that the woman will be taking, but we have to ensure that neither do we starve the women nor do we overfeed the women, so as to ensure that regular normal weight gain should happen. This is the IOM recommendation for weight gain depending on the BMI. And as you see, that women who are overweight and obese are the women actually in whom the pregnancy weight gain has to be regulated, in terms of that in obese women, the weight gain can be as little as 10 pounds, which means as little weight gain as 4 kg maybe. But in women who are underweight, the weight gain can be more. And if this, I find this chart to be very, very effective for management of the weight of the women, and also for prevention and management of gestational diabetes. Now, this, as I said again, that in our countries, there are a lot of myths and misconceptions pertaining to weight gain in pregnancy, and NICE guidelines have actually dispelled the myth that we need to eat for 2. We need to eat for 1 only, and we need to increase the number of calories only by 200 calories a day. And if you look at well-to-do families, we are actually eating more than 200 calories, even in a non-pregnant state. So we do not need to encourage our women to take more calories, but we need to encourage them to make sure that they take a well-balanced and a nutritious diet rather than focusing on the calories alone. 30 minutes of moderate exercise during pregnancy every day is recommended at least 5 days a week, and that plays a good part in making sure that the calories are burnt as well. This, as I said before, that excessive weight gain in the first trimester was associated in 80% of patients to develop a probability of developing gestational diabetes. Now, let's come on to the importance of a good diabetic control. Now, if we get a good diabetic control, we are going to make sure that there's a delay in the long-term and short-term complications and the serious health risks, NCD, which we keep on talking about. If we want to make sure that NCD incidence reduces, we have to make sure that the blood sugar levels are well controlled for the mother in order to help prevent NCDs, which is one of our targets, and it's a very, very important target. Now, what do we want to do when we are talking about medical nutritional therapy? Basically, we want to do nutritional counseling. And it is very important to understand the lifestyle of these patients, to see what they are eating currently, how frequently they are eating, and to send them to a nutritional counselor, or even better, to have a nutritional counselor in your own clinic, or if you or one of your doctors can play that role, that is also wonderful. To make sure to look at the number of calories that they are taking, to guide them to monitoring of the weight gain, importance of BMI, and then control their blood sugar. Now, when I said that this nutritional therapy for diabetes is like other components of gestational diabetes, it is tricky. The reason it is tricky is because there is no consensus on one particular type of dietary approach which is suitable to our gestational diabetic women, which means that we have a variety of approaches for the women, and we need to choose and select the appropriate approach for that particular lady and take her through the pregnancy with good monitoring. Now, a low glycemic diet is recommended for most of the women, and low glycemic diet actually helps in better control of the blood sugar, better fasting plasma glucose levels, better lipid profile in women with GDM, and a substantial decrease in insulin requirement. And that is the reason I have put it first of all, but it is going to become a part of the various diet patterns that we are going to see. Now, if you look at the dietary recommendations, it is recommended that we have to make sure that the women take the sufficient amount of macro and micronutrients which are needed for the growth of the fetus. We have to make sure that these sudden episodes of hyper and hypoglycemia need to be avoided. And that is why, as I said, that we need to have low glycemic index food recommended for the women. We have to encourage appropriate maternal gestational weight gain, but excessive weight gain has to be discouraged. In terms of nutritional counseling, we have to provide them easy to understand counseling. We have to talk to them about healthy plate, about the healthy eating pattern, about the various food options that they can have and what are the ways and the methods of cooking, because especially I can say for Pakistan and some parts of India as well, we like to cook the food a lot and we put a lot of oil and stuff into it. So the food value changes and they may not be suitable for women who have got diabetes. So we have to also focus on the type of the carbs that they're taking, on the amount and distribution of the carbs throughout the day. So sometimes our patients are getting up at 11 o'clock in the morning, taking breakfast at 1 o'clock, then lunch at 3 o'clock, and dinner at 9 o'clock. So they are clumping all the food choices into a very short periods, and that can be a problem for our women. Again, just trying to emphasize that the BMI and its relationship to weight gain must be, it's not enough to stress it. We must stress it again and again, make sure that our women are gaining weight in the normal ranges. And then talking about the importance of physical activity to maintain the blood glucose levels and the insulin levels, and making sure that this physical activity actually contributes to a good glycemic control. And brisk walking can be continued to term, and many women do not feel comfortable with walking. So we have to reassure their anxiety and tell them that it is very important that these women continue their physical activity. Emotional support is very important for them. So when you are trying to take the interesting food away from the women, they don't like it very much. So it is very important that these women are explained, provided emotional support, and they are taken through the pregnancy with a lot of love and care, especially when we are trying to coax them out of their food choices. Now, it's all about food. So we need to tell these women the 3 meals, 3 snacks, and a bedtime snack. We need to talk to them about the amount of food they can take, the amount of calorie count that is appropriate for them, the portion size, the number of helpings in a day, the snack attack, which has to be limited, and what that is kind of healthy snack that these women can take, the glycemic index of the carbs, and the weight management. Now, portion size, as I said, is extremely important. So we need to make sure that the number of carbs is reduced, the carbohydrates are of low glycemic index, and the proteins need to be increased, and the grains that need to be increased. So these are the kind of choices that need to be explained to the women, and they need to understand the concept of portion size. We have to dissuade them from alcoholic beverages, from fast food, from baked food, from fried food, from sugary drinks, candy, very starchy foods, and sweetened cereals, etc. Now, all of the women who are sitting here probably would agree with me that in pregnancy, these are actually the kind of foods that we want to take. So it is creating a disincentive for these foods is actually challenging. So we have to make sure that we swap those foods which are difficult with foods which are suitable for pregnant women. So swapping white bread with brown or multigrain, swapping the chapati with white flour to the wholemeal flour, swapping to brown pitas, and so on and so forth, brown rice, etc., to make sure that the women can make good choices for themselves. And then to make sure that the sugary drinks need to be discouraged. These 0-calorie sweeteners do not do much help. So we need to make sure that we find choices which are suitable for them, which fulfill some of their requirements, and we are able to give them good choices. Now, therefore, the key to success is to provide individualized advice. So people's eating choices, eating habits, and their family requirements might be different. So we have to make sure that the nutritional advice has to be individualized, and it has to be monitored preferably by a specialist. Now, there are various types of diet that are available for these women. So I have just put down a couple of diets. It is individual dieting advice. It is DASH diet, Mediterranean diet, non-nutritive sweeteners, the signal system, portion size, food exchange tables, and keeping a food journal. So these are the various approaches by which we can help the women manage their diet. And as I said, no one pattern is good for everybody. So the first is the conventional approach to diet, in which we limit the carbohydrates and we allow women to take higher levels of complex, low glycemic index carbs and adequate fiber with high consumption of vegetable, etc. So this is the typical traditional convention approach to management of diabetes. The signal system actually divides the food items into three groups, into red, yellow, and the green group. So the green group basically means that you can go ahead and take that food. Yellow means that we have to proceed with caution. And the red basically means that these are the foods which we cannot take. So we map the food into these three groups as is shown in this table. So according to what is there in the red group, we need to avoid those foods in the red group, take the ones in the green group, and the yellow ones we have to take in some moderation. The second is the Mediterranean diet, and Mediterranean diet is a very healthy form of diet. So basically in Mediterranean diet, there are 2 servings of vegetables, 3 servings of fruit, 3 servings of skim dairy products, 2 to 3 servings of legume per week. So moderate consumption of fish and low consumption of red and processed meat. Now, what happens with the Mediterranean diet, and there were studies which were done, and the study actually showed that women in whom Mediterranean diet was provided for management of gestational diabetes, they actually showed a lot of improvement in the maternal and the neonatal outcomes. And this Mediterranean diet intervention, if it is advised early in pregnancy, or if we can advise it to women when they're planning a pregnancy, this actually can help in reducing the incidence of gestational diabetes and improve the maternal and fetal outcomes. So this is again the DASH study. The DASH study basically depends on the DASH diet. DASH diet means dietary approach to stop hypertension. So initially, the DASH diet was for hypertension, but studies were done, the randomized controlled trials were done actually, in which the DASH diet was used to see the outcome in women with gestational diabetes. And the studies that they did, they found out that there was, what they did was that they gave the women the DASH diet for a period of 4 weeks, and the control diet contained 40 to 45% carbs, 15 to 20% proteins, and 25 to 30% total fat. It was rich in fruits, vegetables, grains, and contained lower amount of saturated fat. So what did they find? They found that the patients had better metabolic control. Infants were significantly lower weight as compared to the macrosomia. 46% of women in the DASH group actually needed a cesarean section as compared to 80% chance of cesarean section in the control group. Only 23% of women in the DASH diet group needed insulin as compared to 73% in the control group. So actually a lot of benefit of DASH diet on women with gestational diabetes. So this is actually quite it's a recommended diet for gestational diabetes. Then the next method is obviously, as I said before, that we need to individualize the advice to the diet by the help of a nutritional specialist. And this can be basically be done by looking at the individual choices, looking at the presence of other diseases, and how the woman can follow our dietary advice. And it consists of 2 steps. First, assessing the woman and looking at her eating habits, then using that information to motivate the patient, share have a shared decision making, and negotiate with her to start to modify her diet into a diet which will be good for controlling her blood sugar levels. I'm coming almost to the end of my presentation, and as we all know that we have a lot of challenges in these management. Now, the challenges when the discussion in the previous session was taking place, I was thinking that actually it is only one test which needs to be done universally to all pregnant women. And in the South Asian countries, some of them are doing really well. But unfortunately, in Pakistan, I am very sorry to say that we do not test every pregnant woman, or we do not screen every pregnant woman for gestational diabetes. So actually, we need to put in more and more emphasis on making sure every woman is tested. I think this is the first step to success. If we do not test all women, we are never going to reach anywhere. If we test them, then we can talk to them, we have an opportunity. So I think that not only that we need to educate the patients, we need to educate the patients to ask them to ask their healthcare providers to do a test for blood glucose. But we also have to make sure that we have informal discussions. We have formal discussions with the doctor, make sure that they are dedicated, they are formal, and they implement the guidelines. Because guidelines are available, SAFOG guidelines are available. We have guidelines in individual countries as well. We have FIGO guidelines, we have NICE guidelines. So we have a lot of material available, but the doctors are confused and they lack commitment and dedication to make sure that they screen all the women. Regarding the patients, there are a lot of myths and misconceptions and traditions and lack of responsible behavior on part of many women. So we have to encourage them to develop a responsible attitude towards the pregnancy and to make sure that they take the proper nutrition that is required of a pregnant woman and also of a woman who has got gestational diabetes. And I think that in our countries, we need to make sure that there is integration in the departments and in the national policy, and the government needs to have a national program for gestational diabetes management. Individual efforts, society efforts at small scale will not be helpful. So we need to improve and take up the scale to a full government program for management of gestation screening and management of gestational diabetes. So in the end, I will just share the key messages from my presentation. And they are that the medical nutrition therapy is the bedrock for managing gestational diabetes. The approaches to management of gestational diabetes can vary, but they can be equally effective. More than restriction, it is important that we need to focus on the quantity of diet, the quality of the food, the type of carbohydrates, encourage the women to take healthy diet by taking more vegetables, more complex carbs, and high fiber food. And to make sure that the women are doing just that, we need to monitor, because when we monitor, we are going to modify the nutritional advice for an optimal outcome. To monitor the nutritional advice for optimal outcome, we also need to monitor the blood sugar levels. We need to monitor the gestational weight gain and to see whether fetal growth is adequately taking place or not. Because sometimes doctors who are very enthusiastic or who are controlling the diet very, very tightly or giving too much metformin might find themselves babies with IUGR at the time of delivery. The key to success for nutritional management of diabetes is to provide individual advice, which is supported by the nutrition self-management and supported by a trained dietitian or a healthcare provider who can guide the patient. I think with this, I would like to thank you all and stop over here, and I'm open to questions if anybody has any questions. Thank you very much.
Thank you, ma'am. Thank you for that elaborate and informative deliberation on food choices and lifestyle changes for the management of diabetes mellitus. Over to chairpersons for their expert comments.
Good evening, and at the outset, let me thank Sadhana Madam for having given me this opportunity to talk in the midst of such distinguished faculty and experienced and learned speakers. Now, Rubina Madam, it was a very wonderful talk. And like what Dr. Rubina said, just by diet alone, it's possible to control most of the case of GDM. In fact, when they come for screening, and then you find that the blood sugar level is more than 270, 50, just 2 weeks of diet alone, it's very surprising to see that their blood sugar is fasting and people sugar comes back to normal. So that in fact tells that the importance of diet management is very, very, very important. And especially in a country like India, where from region to region, the way the person eats is so different. What you eat in South India is totally different from what a person takes in North India. So I think it should be specific for that particular area. And now we talk about low glycemic index, but what do we really tell the patient is very, very important that we ourselves know in our community what is the diet which is having a glycemic index. It's important that all doctors themselves know what are the diets which has high glycemic index, what are the diet which has low glycemic index. Only then it is possible to tell the patients. That is important, I thought. And the other thing is, in this escalating prices of vegetables and fruits, we tell a person should eat a T-shaped meal. Half the plate should be filled with fruits and vegetables. When you go to the market and see, it's so costly. I myself think, is it possible for any person to be really following our advice? I think we should really go into the community and see what is available in their setup, see what are the things which are less costly and be able to give the same nutrition. I think we should, it's not so easy. It should be given a lot of importance is what I feel. And like Madam said, split meals is always beneficial rather than taking one meal. In fact, most of our patients say they eat a whole meal once in the morning and then again the same thing they repeat in the afternoon. So I think it's important to give them a split meal. Whatever they take in the breakfast, to take it as 2 divisions. I think that really brings down the postprandial sugar in a lot way. And of course, exercises, I think we should give a lot of importance to tell them to do this exercise at least for half an hour every day should be done. And as all of us know, obesity is a pandemic, and it's important to have this pre-pregnancy counseling. I was really thrilled by the Sri Lankan people who said they come for a pre-pregnancy clinic. Unfortunately, we don't have such things, but I think we should encourage all our patients to come for this pre-pregnancy counseling clinics, and stress a lot on this MNT, because just by MNT, many people can do very well and be without drugs. Thank you so much for this opportunity. And it was really a wonderful talk. Thank you, ma'am.
Thank you, ma'am, for the precious words. Dr. Hira, ma'am, over to you.
Good evening. Thank you for inviting me to be part of this very important webinar. Dr. Sadhana, Dr. Amrita, Dr. Padam Rajpant, and all the panelists and audience. I'm listening to Dr. Rubina after a very long time, and it is always a pleasure listening to her. And she makes such complicated things so simple and very easy to understand. And she has rightly pointed out that GDM is really preventable. And if we take care of the BMI pre-pregnancy, that can take care of prevention of GDM during pregnancy. And thank you for giving a very elaborate and analytical presentation on such an important topic. And she has rightly pointed out that medical therapy is the medical dietary therapy is the backbone of management of GDM, and taking care of the calorie intake. And not only the mother, you have to think about the fetal growth also, because while we are maintaining the weight gain of the mother, the fetus may suffer. So you have to take care of the micronutrients and macronutrients for the optimum fetal growth as well. And rest of the things, I think Dr. Chitra also has emphasized that the dietary counseling by a proper dietitian is very essential, because the obstetrician cannot take care of everything. So expert nutritional counseling is essential as to what is low glycemic food and what are the cheaper options of these foods. Regarding exercise also, the moderate type of exercise, as Dr. Rubina has mentioned, is very important for these pregnant ladies. And I think overall it gave such an insightful view to all the audience, and for me too. And so we should have a proper guideline for these weight gain and optimum weight gain during pregnancy, as she has mentioned, the Institute of Medicine guidelines. As she has mentioned, the management should be individualized for every woman, as all the women have different type of constitution. So congratulations, and thank you so much for giving so much knowledge for the management of GDM. Thank you.
Thank you, respected chairpersons. Thank you, Dr. Rubina. So now we quickly move on to the third session, and the topic is oral hypoglycemic agent in GDM. And speaker is none other than Dr. Sadhana Gupta, ma'am. She is the co-chair of NCD committee of SAFOG, and she has been the representative, FOXY representative to SAFOG in the past 2 years. And she has been our vice president of FOXY in the year 2016. I cordially invite the chairpersons for this session, Dr. Ashma Rana from Nepal. She is Professor OBGYN, Kathmandu, Nepal. And she is also the president of Perinatal Society of Nepal from 2021 to 2023. And she has been awarded many a times, and she has special project on screening tests for diabetes in pregnant women, 1996 to 1997. It was a research grant from Tooth. Our second chairperson is our very own Dr. Anita Rajoria from India. She is head of the department and senior consultant at Dr. Hegrewar Arogya Sansthan of Delhi. And she is affiliated to various prestigious medical organizations, achiever of many awards, and has been an invited faculty at various webinars and conferences. She's a very active member of many committees of OBGYN Society of India. So over to Dr. Sadhana Gupta for her deliberation. Ma'am, you're muted. Sadhana ma'am, we can't hear you. Yeah.
So with a wonderful deliberation and sharing of experience, now we are coming to after maternal nutrition therapy, which is an ongoing part for the management with or without drugs. I will take briefly about the oral anti-diabetic agent in hyperglycemia and pregnancy, which is a real gray areas, and we have a lot of things to learn and gain from the experience. So I bring greetings from various professional organizations whom I have served, and as a FOXy representative to SAFOG, this has been one of the most contending experience to be the so much sharing of knowledge and experience. So we say Western world is different and our area is different. Are we prone to diabetic as a race, or it has been a sharp change in lifestyle? This is a question to us, but we have GDM always around the corners, and we all need our own specific solution. Now, coming to oral anti-diabetic agent in hyperglycemia and pregnancy, what are the issues? What patient want? Good control, good outcome, safety for mother, fetus, and newborn. They are concerned for side and adverse effect as well as long-term consequence in offspring. Healthcare system, especially when we are dealing with a heterogeneous population, side by side, not that good economic inputs by the government for the healthcare. We seek for cost and convenience. So we have to look the balance so that what we can do best for our people. So one important thing is when maternal nutritional therapy is when we should start pharmacotherapy. That is a very, very important question, because now in clinical practice, when we have a lot of sensitization, we see one single value of 160 or 156, and the patient has been advised the pharmacotherapy. So one very, very important deliberation with the Cochrane database, that when 30% of blood glucose values in week are above target threshold, then we should start pharmacotherapy, and it may be any drug, it may be insulin, or it may be the oral hypoglycemic agent. So this is very important, that don't give a knee-jerk reaction to one or occasional single value when patient had mangoes or some party, but look what was happening last week, and if 30% are above target hold, then you switch over to the pharmacotherapy. So still the many recommendations are for insulin. Still insulin is a gold standard treatment, but because it is effective, we have a long experience for safety of mother and fetus and newborn, and we can adjust very quickly with the glucose level, with the insulin level. So insulin has been a gold standard, but always issue, there are a need for injection, training issues, need for refrigeration, good temperature, training of care provider and patient, and skillful handling of syringes, that is the biomedical waste disposal. And we have around 10 to 25% incidence of GDM in South Asia. So that has given the lead to many research and trying with the oral hypoglycemic agent. And still, what is the gold standard statement, that it can be considered as alternative to insulin when pharmacotherapy is indicated. Likewise, we have a 30-40% value above target level, but we are not sure that the patient can comply with the insulin, or patient decline insulin, and they can be an acceptable first-line approach in select patient, especially, again, an important message, that normal fasting blood glucose level, but a modest postprandial hyperglycemia. So these are the important place where the oral hypoglycemic agent has got their own role and place in the management of GDM. We have studied glyburide and metformin has proven to be much safer and effective drug. So what is metformin? As a obstetrician, we might not be knowing, but we must know that basic of this drug, that it is a second generation biguanide. It reduces gluconeogenesis in liver and limits glucose absorption in gut. Why it is important? It does not increase insulin production. So it is less likely to cause hypoglycemia. It also does not stimulate fetal pancreatic cell to produce insulin. So less likely to have neonatal hyperinsulinemia and neonatal hypoglycemia. So these are two important things in favor of metformin. Half-life is 2 to 5 hours, and mechanism of clearance is by renal tubular secretion. And when we have increased GFR in pregnancy, it may reflect for the dose adjustment. So we have got a few important big trial in the 2,000 to 4,000 people. And they say that it is effective, but there is no long-term data for the safety of newborn. So this is few trials which I've seen. It has shown no difference in first degree composite outcome, less neonatal hypoglycemia, large for gestational ages comparable, less maternal weight gain, and it is more acceptable. And there are few studies which show that the primary outcome is good with the metformin in management of gestational diabetes mellitus. There is also reduced risk for pregnancy-induced hypertension. But few important things with the good control of metformin in a right patient, it is important to note that around 34 to 40% of the patient with GDM who are treated with metformin had the treatment failure. So metformin alone in around 34 to 40% patient, it was not sufficient to control the blood sugar level in GDM. MIG trial, which again says that the 46.3% women needed supplement insulin to maintain euglycemia. However, there is no neonatal adverse effect like RDS, preterm birth, or the hypoglycemia. TOFU trial, which is a very important offspring follow-up study up to the 2 years of the age. And they say that the women who were treated with metformin had more visceral fat on the shoulder. And whether it is significant, whether it is due to drug or the insulin sensitive, we actually don't know. But again, there is a caution because we don't have the long-term effect of the drug on the offspring, and that says a little caution about the routine and the rampant use of metformin. Like we cannot say that every woman with GDM diagnosed and need pharmacotherapy, we can prescribe like folic acid or iron, that metformin. We have to be cautious, and it has to be communicated to women that the insulin can be the safer and the more tried drug for the GDM. What is the dosage? It is 500 milligram. Start with 1, then 1 BD, and you can go maximum up to 2000 milligram. Side effects, especially GIT, that nausea, anorexia, diarrhea, especially in pregnancy, woman does not feel very nice with the anorexia. And this is also important because in clinical trials, almost 2% of women discontinued metformin because they are not happy with the side effect. Another important thing that the metformin level cross the placenta in contrast to insulin, and the fetal level are 200% of maternal level. And that again says the question that we actually don't know the long-term consequence of metformin in offspring because there is a very, very high level in the fetal level. However, for breastfeeding, it can be used safely in postpartum period because the transfer in human milk is minimal. Various professional bodies are inconsistent, and still many associations does not recommend oral anti-diabetic agent as a first-line treatment. This is very important. Again, a very important message that the American Diabetic Association recommend avoiding metformin in patients with hypertension, preeclampsia, or the women who are having a risk for IUGR. And the basis is that the metformin suppress mitochondrial respiration, which may have the adverse effect on the growth or differentiation of fetal or placental tissue. Again, the different professional bodies are on different page, but we must be quite cautious of it. Glyburide is the second drug. Once upon a time, when we started oral hypoglycemic, there were papers on first on glyburide, then on metformin. So it is a second generation sulfonylurea, and it stimulates release of insulin. Onset is 1 hour, and it enhances insulin sensitivity in peripheral tissue. Another important thing is that it does not cross placenta in significant amount, but actually for the practical purposes, doses is also convenient. It is 2.5 to 5 milligram once daily, but because it produces insulin secretion, the maternal hypoglycemia and the neonatal hypoglycemia were more common side effects with the glyburide as compared to metformin. So there has been studies comparing with insulin and glyburide has not proven that safe and that effective drug, because glyburide has got increased birth weight, increased macrosomia, increased neonatal hypoglycemia, and the trend toward the increase the large for gestational age. So glyburide is not considered that effective drug in the GDM management, though the largest RCT Lanka trial on 404 patients says that it achieved good glycemic control and a good compliance and a good, like easy, the patient take the drug very acceptably. Again, it says that it is higher rate of NICU admission, RDS and hypoglycemia in neonate, and the neonatal complications are more with the glyburide, and failure rate is again 50 to 30% with glyburide. So when we compare two drugs, metformin and glyburide, as a monotherapy, glyburide is inferior both to insulin as well as metformin. Metformin with or without insulin can be considered in select situation. Like if we have the treatment failure with metformin, we can go with the one dose of insulin rather the multiple dose of insulin, and again the combination therapy can be a good choice for it. So insulin supplementation with metformin can be very easier. So still the debate is over, should we use oral hypoglycemic agent universally? Still it is not, the debate is not over. We have to give the right patient for the right drug. So what we say, the normal fasting, postprandial, modest rise, then we can switch, and the patient is not complaining or decline insulin, then the metformin comes to our rescue. And this is a study what we are doing, that what we have been listening to all the country perspective, there has been variation. And for family physician, like general practitioners, many times write glyburide very nicely that it is blood sugar level, and sometimes they don't understand that we need to achieve a strict blood sugar control in pregnancy because of the fetal and the neonatal effect, while the experts are more likely to use insulin for the management of GDM. So professional body's recommendation, because we are not on the same page, there are different, and still oral hypoglycemic agent have got the gray areas, and we have to be very careful about it. Still they are in category B. Now we have changed the safety of the drugs in pregnancy and lactation, and the pharma company have to write what is their experience in pregnancy and lactation, and it is no categorization. But it makes again the decision making by clinician more complex, because it is not a simple way that it is B drug we want to give, it is B drug, and we have to read all the experience by the pharma company which they gives to us, and it is so difficult to read about all the drugs. Our last word about inositol, because what we as a South Asian, we are very happy with the nutritional therapy. Whatever we can have in the food, and if it has got a positive, we are very acceptable. It sounds very good to us, and rightly so. So inositol, can they reduce the severity of GDM? Can they reduce incidence of GDM? There has been a few good papers. Dr. Hema Devakar also have done a wide multicentric study about role of myoinositols, and they say that the dose of myoinositol 2000 milligram, 200 microgram. There are few papers who say that it has got some role in prevention of GDM and the reducing the severity of GDM or reducing the dose therapy. So we have to have, there are few papers who are giving some very good results, some are not sure that of its efficacy, but as South Asian country, we can really work on it because we have the almost highest population of GDM. Gut microbiota is again a theory which can cause that there is a change in the gut microbiota that cause diabetes, preeclampsia, and can probiotic help in reduction of GDM in our setting? It is again a matter of future research, as well as the need of oral insulin, because when we have 10 to 30% or 40% of population with some sort of impaired glucose tolerance, we may need oral insulin. That will be the gold standard drug with the oral route. And the research, there are phase 1 trial has been done and the alternative routes are the buccal and the inhale. So the takeaway that we have to make, as a race, South Asian are prone to diabetic. I think we can prove when we have the aggressive effort for offensive commercial industry for the junk foods and for all the things and the sedentary lifestyle, oral anti-diabetic agent have got a very specific and carefully selective place, and we have to take care of the failure rates as well as the long-term consequences. And for even oral anti-hypoglycemic agent, we need to have the close maternal and fetal surveillance, which is needed for all HIP. Because patient is on insulin, they are prone to have more surveillance. When they are on drug, they may take it lightly. Inositol and probiotic may have the future preventive role in prevention and GDM management, as well as the oral insulin. So we as a country, we have to create evidence by sharing experience, for which we are today here. And as we are catering to the largest heterogeneous population, our experience and voice matters. So thank you once again for being always together, and we look forward to many, many such fruitful association in future. Thank you very much.
Thank you, ma'am, for that very wonderful talk. Now over to chairpersons, Dr. Anita and Dr. Ashima, for their expert comments.
So thank you, Sadhana ma'am, for highlighting that, monitoring of blood glucose, and you find that more than 30% values are beyond the range, and your sugars are not under control despite medical nutrition therapy, maintaining good physical activity, stress and weight management. You start on pharmacotherapic agent, initially oral. You very well highlighted the importance of using metformin. I just want to add that it was said that metformin is much safer after 20 weeks of gestation. I would like you to comment on that. And moreover, there is no role of combining metformin and glyburide together. So that is beyond any doubt. And Americans are more, are in use of glyburide for GDM as such. You had highlighted one important thing, that these oral anti-diabetic agents may be taken with care in PET and IUGR, these patients, because you very well highlighted that metformin causes mitochondrial respiration suppression. So it may have some growth hampering of placenta as well as fetal tissue. But none of the association like American Diabetes Association or Society of Fetal Medicine has given it as a caveat for use. It can be used, but with caution. That was the one thing I just wanted to impress upon all my delegates who are attending. And of course, if not controlled by even oral pharmacotherapeutics, then insulin is our next, savior. So we will be listening Dr. Anuj regarding that, and we are looking forward for his presentation also. So I will like you to make one comment about use of metformin after 20 weeks of gestation.
So Anita, thank you very much for this question. Actually, the preferred is that always in the second trimester we should start metformin if we are wanting. And why it is again a gray area, because in PCOS women, it is recommended that if the woman is on metformin, that they should be continued in the metformin to reduce the miscarriage rate and the other complication. So my comment is that for PCOS women can be different, and metformin, if they are already in the preconceptional period, they can be continued. But for all practical purposes, if it is hyperglycemia in pregnancy, the metformin should be started after 20 weeks and not before that, because we don't know that it has got. And even in my practice, even in PCOS women, I'm a little skeptical about use of metformin because it is first trimester and a lot of organogenesis. And likewise in the third trimester, who are on metformin even, we have my clinical experience that in last trimester, again, there is a issue of failure, and the labor management sometimes become very difficult with the oral hypoglycemic. So still the first gold standard is insulin, and Dr. Anuj will say that the complex treatment can be made very, very simple, and oral hypoglycemic second choice in select situation with the word of caution. That is the final my takeaway.
Yes, yes. Thank you, Sadhana ma'am, for those comments. Even some studies, they said that glyburide is used. Like
glyburide, yes, has not, yes, it has not.
It should be stopped at least 2 weeks prior, because otherwise it causes prolonged, sustained neonatal hypoglycemia. So I think it should be used with a caution. Even metformin, we have to be very, very cautious. Their results are comparable as far as, weight gain of neonate was concerned, or neonatal hypoglycemia was concerned, but there was this point that glyburide causes more persistent glycemia. So it should be given with a caution, and it has to be stopped at least 2 weeks prior.
My indirect message was no glyburide. Indirect message, and secondly, that this is also very important, that if the patient has suffered previous adverse obstetrical outcome, then the insulin should be the choice and not metformin. If there is any stillbirth or something adverse outcome, then the insulin again is the choice.
But something is always better than nothing. Our patients who are of rural background, who cannot afford daily injections or can't have them on their own, definitely because of lower cost and ease of administration, our patients do prefer metformin.
I will like to comment on it, Anita. My 40% patients are rural, and actually once you explain them, they really follow much better than the urban people. They really do the good thing, and how good obstetrical outcome we have given to them, and we have to believe them and just make a sympathetic training and how to keep it, and they follow more religiously than the urban population.
Yes, ma'am. Yes, ma'am. Our good counseling always matters regarding insulin administration, as well as self-monitoring of blood glucose also. Because the pens are available, they are very comfortable. If they are minimally educated, they can do self-administration of insulin. So we are looking forward to hear Dr. Anuj Maheshwari sir regarding that. So over to you, Amrita, if the chairperson is...
Yeah, over to Dr. Ashma, ma'am.
I'm not seeing Dr. Ashma. Actually. Ashma, are you there? Actually, doctor's name is Ashma. Actually, few people have not renamed.
So I think we can go on with the next.
Dr. Anuj is waiting, yes.
Okay. So now we move on to the last session of today's webinar. It is Insulin in GDM, Simplify the Complexity. And speaker is Dr. Anuj Maheshwari from India. He's professor and head in medicine, Babu Banarsi Das University, Lucknow. He has presented many papers, and he is the recipient of many awards, namely the Health Icon in the year 2017 and 2019 also. And he's a well-being champion also. So I now cordially invite our chairpersons on this platform. We have none other than Dr. Shyam Desai as our chairperson. He is the president-elect SAFOG year 2023 to 2025. He's a teacher at Mumbai University, and he's a consultant OBGYN and endoscopy at Hinduja Hospital and Nanavati Hospital. He has also been the past president of FOXY in the year 2005. The second chairperson is Dr. Mriganka Saha. He is also a teacher, and he's an assistant professor, Obs and Gynae, College of Medicine, and JNM, WB, UHS. And he's the president, Kalyani Obstetrics and Gynecological Society. He's an achiever of Foxy Kamni Era Oration and associate member of RCOG UK. So over to the speaker, Dr. Anuj Maheshwari for insulin and GDM.
Thank you, Dr. Amrita, for kind introduction. Thank you, Dr. Sadhna Gupta, for inviting me and all SAFOG group for giving me this opportunity. And I am really impressed with the previous speaker's talk on the oral hypoglycemics and wonderful summary done by Dr. Anita Rajoria. It was a really intellectual summary. So let me share my slides and I will try to start from where you left, and that is that complexity of the insulin. I believe that all complexity of the insulin arises from one step, that is patient does not listen. Why do it happens? Patient does not listen because we don't say to the patient, we are not enough say to the patient that elevated maternal glucose or high HbA1c level during embryogenesis is associated with high rates of the spontaneous abortions and major malformations in newborn. Otherwise, people are ready to do anything for their newborns. Unfortunately, in India, we see a lot of unplanned pregnancies. Approximately 2/3 of the women with diabetes develop the unplanned pregnancy. Even out of diabetes also go, that number may be little more longer, a little more larger. So what is important that we should do in the preconception counseling, that risk of malformation, we should tell the patient and her relatives that what are the adverse outcomes of maternal diabetes, especially if it is running into the pregnancy. If a lady is keeping the hyperglycemia during the pregnancy, what wrong is going to happen with her as well as for the next generation. We have led a campaign in our part of this country, in which we have given a slogan, "Ek jaan se bache do jaan," means one check of the glucose can save the 2 lives. One is the present generation, that is the mother, and another is the next generation. So it is the important to tell all these things to the mother and her relative, especially the husband. Use effective contraception till her does not come to the normal glycemic. Genetic counseling is also important, and this is the right time to switch to insulin instead of waiting to get her pregnant and then to think about which insulin is to be started and when to start in an embryogenesis period, maybe meeting with the hyperglycemia and causing a lot of harm despite giving all insulin and everything what it should be done we are doing, but still the patient is getting a lot of disadvantages. So how to begin with? First of all, we should teach the mother SMBG, self-monitoring of the blood glucose. We should stop her oral hypoglycemic, optimize insulin therapy, control blood pressure with safe antihypertensive. What are those? Stop ACE inhibitors. Most of the patients are taking the ACE inhibitors because of the hypertension. And statins should also be stopped at that time. We should have a good follow-up in 1 to 2 months interval. Until then, we should ensure that contraception is being there. Medical nutrition therapy should be started before entering into the pregnancy. Self-administration of the insulin and self-adjustment of the insulin dose must be taught to the patient so she can do it on herself without taking the help of the your clinic or my clinic. Education about the hypoglycemia is also very much important, and physical activity, how much she can do and what are the ways to which the physical activity can be continued during the pregnancy. It is very much important to make her learn. So what is the target before entering into the pregnancy? HbA1c must be kept 6.5%. Target blood sugar in preconception when the pregnancy has not started must be kept less than 100 at the fasting of the 8 hours, and 2 hours postprandial should be less than 140 mg/cent. Now the question arises, what should be done in the gestational diabetes? Because gestational diabetes is recognized only after the conception has taken place. So we should really find or identify the women, those who are having the history of diabetes in their families, those who are the first degree relatives of the diabetic individuals, at the same time those who have been obesity, as well as they might have been having some sort of the hyperglycemia in their previous pregnancy, or their mother might have developed a pregnancy in hyperglycemia during her pregnancy. So all these are on the higher risk of getting the hyperglycemia in the pregnancy, and they should all be checked for the pre-gestational diabetes as well as for the insulin resistance, which must be running, and maybe the pre-diabetes which may be running in that woman before entering into the pregnancy. If it is there, it is to be corrected, and insulin is the right thing to be correct for that. And during the preconception care, we must tell the patients about the hypoglycemia. What is hypoglycemia? How does it harm? It is really harmful for the forthcoming child or not. There is no evidence that hypoglycemia is an independent risk to the developing embryo. So it does not harm to the embryo or forthcoming child. But definitely mother may be having risk. But I must tell you, during the pregnancy, we have seen mothers touch the lowest level of the glucose up to 55 at the 2 a.m. in the morning, and that is equivalent to the hypoglycemia. But during the pregnancy, it does not cause harm because of the hormonal status of the pregnancy, hormones, anti-insulin hormones secreted by the placenta. So a good antenatal care is the earliest identification of the pregnancy. After that, we must check the blood glucose for the first contact, as and when the woman knows about her pregnancy, it should be checked for the hyperglycemia. If she is having the hyperglycemia, then this is the right time to check for the HbA1c. And that will tell you whether this lady is carrying the diabetes before entering into the pregnancy or not. And target blood sugar after the pregnancy has started should be preferably 90 or less than 90. In Indian subcontinent, DIPSI says we should keep it 90 because we are more metabolically prone as compared to our Caucasian counterpart. They are supposed to be at 95. Not much difference is there. Different organization might have been giving the different cutoff, which are not really very much different. 2 hours post glucose of the 75-gram glucose, or 2 hours post meal, it should be 120 or less than 120. That should be the target. So insulin is the preferred treatment for gestational diabetes for a safe mother and child. Let's tell about the blood glucose level, what should be maintained during the pregnancy. Across the pregnancy, fasting plasma glucose should be maintained between 80 milligram to 90 milligram, and postprandial glucose should be maintained between 110 to 120 milligram. So that the mean plasma glucose should be maintained between 95 milligram to the 105 milligram per deciliter, and that is the way through which we can keep the microsomia away. When we can ensure that birth weight of the forthcoming child will be between 2.5 and 3.5 kg, means neither it will be macrosomia nor it will be low birth weight. So what are the available insulin formulations which are with us in India and the neighboring countries, or in the countries which are of this South Asian subcontinent? We are having in our part that human insulin, regular, short acting, which is the soluble insulin, NPH, which is the Heiji insulin, and we can also have the premix solutions of these two insulins, the regular maybe in the 30% and NPH 70% and 50-50 combination is also there. Analog has been recently introduced for 10, 15 years, 20 years before they have been introduced, and they are actually working for the rapid acting, and they are better for taking care of the postprandial hyperglycemia. They are also available in the premix 30-70, 25-75 and 50-50 ratio. There are certain long-acting analogs like detamate, which are approved in the pregnancy, but glargine is not approved in the pregnancy because we have not got enough data with that. But still, I must say that this is frequently prescribed insulin in the pregnancy. And many a times it happens when a lady who is already taking the insulin glargine enters into the pregnancy, then it is recommended to continue with the glargine instead of making her uncontrolled after withdrawing the glargine. And during the embryogenesis period, this hyperglycemia may be waxing and waning and causing a lot of harm to the forthcoming child. So insulin glargine is not recommended to start in the pregnancy, but if a woman is using it before entering into the pregnancy, it should not be stopped. At the same time, I must tell you there are certain studies, although they are not enough in the number of data to be acceptable, but there are studies that says that glargine does not cross the placenta. But apart from that, we are already having the insulins which are well approved to be used in the pregnancy, like NPH, Detmir, Lispro, Aspart, all are the category B molecules to be used in the pregnancy. Let me not forget to tell you that insulin is not a thing which is very much mandatory for the gestational diabetes. I must tell you that 80 to 90% of the gestational diabetes patients can be very well managed by the medical nutrition therapy if it is being done by very appropriately. What is the appropriate? Many of the times we should choose the low carbohydrate diet. We should choose the low glycemic index carbohydrate. We should split the breakfast or the larger diets into the 2 parts or sometimes into the 3 parts. We should avoid the sugars which can have the more hyperglycemia impact, more frequent eating, but not in the major amount. So these things really help us keeping the glucose level within the appropriate limit without using insulin for a longer time is in the pregnancy. So, but we must not forget that as the pregnancy progresses, glucose intolerance typically worsens and patient may ultimately require insulin therapy. So sometimes we, despite our all effort, despite doing all these things, what we should do, at one point of the time, insulin becomes mandatory. What should we do? Who are the patients in which the insulin should be immediately started? If you find any patient with fasting plasma glucose 120 or more than 120, this is the patient who needs the insulin immediately. Others may be seen within 3 days and they may be taught SMBG during this period, which may be performed before breakfast and after 2 hours of the meal. And on the basis of those readings, we can take the decision whether to initiate the insulin or not. In a patient of the GDM, it is advised that 2 weeks a medical nutrition therapy should be given before starting insulin. But if the glucose level is very high, like I said that it is more than 120, in gestational diabetes, it is said that it should not be more than 105. If it is more than 105, then it is not a time to wait for medical nutrition therapy for 2 weeks. So medical nutrition therapy is to be continued only up to the time when fasting plasma glucose is 90 and it is keeping more than 90 and 2 hours post meal is keeping more than 120, then it is the time to initiate with the insulin. No more medical nutrition therapy will work in such kind of a patient. So let's see who are the patient in which the initiation of the insulin is required. As I already said, if the GDM is there, then fasting plasma glucose 105 is the cutoff to start the insulin immediately. Apart from that, if a patient is maintaining medical nutrition therapy less than 90 fasting glucose, then you can definitely go ahead with that. But between this, you should think about starting in the insulin after giving the 2 weeks trial of the medical nutrition therapy. As far as the postprandial plasma glucose is concerned, if it is 155 or more than that, this patient is requiring the insulin. If 2 hours postprandial plasma glucose is 130 or more than that, this patient is requiring the insulin. So if the fasting plasma glucose initial is high, initial dose of the intermediate acting insulin is 4 units to be given before breakfast. We can start in the pregnancy with the 4 units of the insulin if the fasting plasma glucose is not appropriate to our guidelines, or fasting plasma glucose is not desirable. If prandial hyperglycemia is there and fasting plasma glucose is normal, then we can start with the regular insulin, and that also to be the same meal before the meal which is showing the prandial hyperglycemia. If a patient has elevated pre-lunch blood sugar, regular insulin can be added to the NPH or intermediate acting insulin at the time of the breakfast. So if the fasting plasma glucose is high, NPH is required at the time of the breakfast. If a patient is showing that pre-lunch blood glucose level is also out of the range, then regular insulin also to be added at the time of breakfast. The above regimen of the regular and intermediate acting insulin in the morning controls the hyperglycemia in most of the cases. Many times we see gestational diabetes gets very well controlled by these kind of the combination. In many times we have seen that gestational diabetes shows only the prandial hyperglycemia, and in such type of the setting, only the prandial insulin is required before the meal. Many times it works if it is given only with the highest meal or the meal which is carrying the highest calories. Despite doing this pre-breakfast insulin, if a lady is keeping the post-dinner blood sugar is high, then it demands a small dose of the regular insulin before dinner, in addition to the regular and intermediate acting insulin which is being given in the morning before breakfast. But at the same time, we must ensure that lady is doing the self-monitoring of the blood glucose at least once in 4 days. Combination of the regular and intermediate acting insulin, which has been set by me at the time of the breakfast and at the time of the dinner, may be necessary to be added with simple NPH if the fasting blood sugar is still coming high. Means we are giving the NPH and regular insulin combination at a time of breakfast. We are giving a regular insulin at the time of the dinner. But despite that, our fasting blood glucose is coming high, then it is the time when we should add the NPH second dose at the time of dinner. This combination of the short and intermediate acting insulin in the morning and as well as in the evening is known as mixed and split dose of the insulin regimen. This makes the scenario a bit complicated. In this regimen, we must follow that 2/3 of the total daily dose of the insulin is to be given in the morning and 1/3 in the evening. But that does not work always with the patient. Sometimes patient's requirement may be different depending upon the taking of meal or amount of the calories which are being taken into the meal. Many a times, many ladies, especially in India, take very little breakfast. So sometimes they may not be requiring a big amount of the insulin at the time of the breakfast, but they may be requiring a big amount of the insulin at the time of dinner. So this rule will not always be there, but initiate with this kind of the rule. For each combination, 1/3 dose should come from the short-acting insulin and 2/3 dose should come from the intermediate-acting insulin. With this regimen, if the patient continues to have the fasting hyperglycemia, the NPH or intermediate-acting insulin has to be given at bedtime instead of before dinner. So this is another option. If you are giving before dinner, still the patient is showing a little fasting hyperglycemia, you can take from the before dinner to the bedtime. So 2-3 hours difference will make a much difference in the level of hyperglycemia. If a morning insulin requirement is 18 units, this is for just example, the ratio of the short-acting insulin will be 1/3 and 2/3. So 6 units will come for the short-acting insulin and 12 units will come for the longer intermediate-acting insulin or NPH. But in the case of the evening dose is always lesser than the morning dose. If the 18 units is required in the morning and 12 units is required in the evening, then this will be again splitted in the same fashion that insulin, short-acting insulin would be the 4 unit and the NPH would be required in 8 units. So these rules should always be kept. Remember, your patient will never meet any hypoglycemia. Now, in India and the other, and in this subcontinent, many of the clinicians, including the obstetricians as well as physicians, they prefer the premixed insulin very much because 2 or 3 shots of the insulin are usually not preferred by the patient as well as not preferred by the clinician. So if we need to start with the premixed insulin, 3070 is the most popular make of the insulin to be start with the 4 units before breakfast. Every 4th day, you can increase 2 units till it reaches to the 10 units or it achieves the glycemic correction. What is the glycemic correction? Less than 90 at the fasting after 8 hours and 2 hours post meal, it should be less than 120. If it is there, then you don't do anything, continue with the same. If it is not there, if it is higher than this, then this is the time to add the 6 units of the regular insulin before breakfast and the same amount of the premixed insulin before dinner to correct the fasting plasma glucose. Doses may be little bit different also, maybe requiring more also, or maybe less also, depending upon the insulin resistance of the women. The women, those who are having the obesity associated with the pregnancy, they may be having the requirement of the insulin much more. Review with blood sugar test, adjust the dose further. Total insulin dose every day can be divided as 2/3 in the morning and 1/3 in the evening, as we have already discussed. Sometimes we see that many women are having the plasma glucose level post-breakfast very high. So there are the two methods. Either you should switch over to the premix 50-50, but before switching over to the premix 50-50, a very important thing must not be forget that we should split the breakfast into two parts. If we can split the breakfast into two parts and it gives the desired result, then probably it can save the addition of the insulin. A few GDM patients may require combination of the short-acting insulin and intermediate-acting insulin in the morning and evening. The preparations which have both regular insulins and intermediate-acting insulin in the same cartridge or disposable pen are available now and can be used to initiate insulin therapy. So we can use the pen injectors. They are very much useful and they are very easy to use, and many a times they are just painless, and many young women accept them with easily. If 2 hours post glucose is more than 200, we must think that this lady might be carrying diabetes before entering pregnancy. A starting dose of this kind of the patient must be 10 units of the premix insulin, could be administered straight away before breakfast, and the dose has to be titrated on the follow. Along with insulin therapy, medical nutrition therapy is again the rule. It should always be continued. It can never be dropped. Importance of the postprandial control in pregnancy is very much, as I already said, either it is GDM or it is the diabetes in pregnancy. Postprandial hyperglycemia is very important to be kept under control. Several studies have shown that postprandial hyperglycemia is more predictive of the adverse neonatal outcome than fasting glycemia. If postprandial blood sugar is high with human insulin, then this is the time to opt for the short-acting insulin analogs. You can use Lispro and Aspart, and now you can use the PS also. A few women which may require short-acting insulin 3 times a day with meal and bedtime intermediate insulin or NPH, this situation must be taken care or well monitored by the physician, diabetologist, endocrinologist, or gynecologist combination team. Many times we see that women with gestational diabetes do not require more than 20 units of the insulin per day for the glycemic control. But the women, those who are having the type 1 and type 2 diabetes, they may be requiring more amount of the insulin. So if a lady is requiring more amount of the insulin, we must keep this thing in mind that she may be having type 1 or type 2 diabetes before entering into the pregnancy. Pre-gestational diabetic women, type 1 and type 2, during pregnancy may require high dose of the insulin. A few may require multiple daily injections, usually given as short-acting insulin before breakfast, lunch, and dinner, and intermediate or acting insulin or NPH before dinner. So insulin dose is always individualized, has to be adjusted on follow-up. But very important thing which I am going to tell you, if insulin requirement drops suddenly without any good reason, then we must think about the placental insufficiency or fetal jeopardy which might have been occurring. It may also be due to the increased utilization of the maternal glucose by the supercharged beta cell mass of the macrosomic fetus. Many times the maternal glucose has been started well handled by the offspring's pancreas. If it happens, again, it is very much harmful for the offspring. It may develop the weight of the offspring. At the same time, macrosomia will be there, but at the same time, that child will be more prone to develop diabetes in the early part of the life. It is appropriate to use the dose needed to achieve near normoglycemic levels without undue concern about giving too much insulin to our patient. Many times, many patients' relatives are concerned about the amount of the insulin. So you need not to be concerned about the amount of the insulin. You must concern about the amount of the glucose what the female is carrying. Main concern should be the blood glucose results rather than the dose of the insulin. It has been told by the Lanka. So insulin treatment during delivery is again a very important part. If labor is to be induced, the usual evening NPH insulin should be given in the night before, but no subcutaneous insulin is to be given in the following morning when induction is started. A similar approach is to be followed in gestational diabetes or in the diabetes in pregnancy, both variety of the patient. Goal is to maintain the glucose concentration between 80 to 100 while the labor is going on. Most labor and delivery units have the ability to measure the glucose by using the glucometer, and this should be done every hourly. If labor is to be induced, then IV saline is infused until active labor begins. So to maintain this between 80 to 100, we can use the IV glucose as well as IV saline, or depending upon the need of the insulin. So if a patient is maintaining between 60 to 90 milligram per deciliter, it's enough to give the 5% glucose with 100 ml per hour speed. If it is between 90 to 120, it is the desirable. So we can work with the normal saline only. If it is more than 120, then we should add the insulin to the normal saline, and 4 units is suggested, may be required more depending upon the insulin resistance of the patient. If it is between 148 to 180, to initiate with 6 units of the regular to be added with the normal saline. If it is more than 188 units of the regular insulin can be added with the IV fluids. Lactation. Insulin is saved during the lactation period. So let's come over to the take-home message. Ensure optimum controls, that is the 6.5 HbA1c or less when the pregnancy has not started before entering into the pregnancy. Start insulin with the medical nutrition therapy and lifestyle modification together. Advise contraception till the target HbA1c is not achieved. Appropriate choice of the insulin regimen is very much important so as to meet the goals of the glycemic control. Many a times our choice of the insulin is not good because of what? Patient does not show glycemic control well. Focus is not only to achieve a good maternal glycemic control with the objective of achieving ideal birth weight with no neonatal problem, but also to avoid congenital malformations and maternal complications. Stop the next generation and mother becoming diabetic. That is the biggest goal for any clinician, any obstetrician, or any human being of our country and in this part of the world. That is the most important thing and most important target to be achieved. That's why I always say use the insulin for the correction of the hyperglycemia during the pregnancy. Thank you very much for the kind listening.
Thank you, sir. Thank you, Dr. Anuj. You really simplified the subject. Now over to the respected chairperson, Dr. Shyam Desai and Dr. Mriganka for their expert comments.
It was a nice presentation. And before I speak anything, there is the teacher of the teachers, Professor Sam Desai sir is there. So he should start, then I will do my inputs.
Thank you, Mriganka. Can you hear me and see me?
Yes, sir. We can see you.
So that was indeed a very good, comprehensive and practical aspect of treating insulin, diabetes with insulin. The important thing is to control the hyperglycemia before the patient conceives and then regulate the dose of insulin as per the medically advised regimen, not only during pregnancy, also in labor and subsequently post-delivery as well. It was indeed a very good account of insulin therapy. And I'm so happy that we could have Dr. Maheshwari presenting this particular aspect. Thank you so much.
Yes. Yes, Dr. Mriganka, over to you.
Thank you, sir. Thank you, Sadhana madam, for organizing such nice program, and lots of my known Rubina madam, starting from everyone, Anita madam, everyone is known to me, and Dr. Anuj Maheshwari. It was a really nice, comprehensive guide to the obstetrician. And one thing is that basically the gestational diabetes is divided into the two categories, pre-gestational and gestational diabetes. The lots of the fetal anomalies and the complication along with the maternal complication, vasculopathies, these are all related with the pre-gestational, where the strict control of the blood glucose, if you don't do, then it will end up into complication. The gestational diabetes, which develops that in during pregnancy, the macrosomia is the main complication, fetal complication, not such maternal complication. I have also never seen, I may not be the expert or like that, what in my experience, I have not seen so much maternal complication in pure gestational diabetes mellitus. Only thing is that the abdominal circumference at the 32 weeks, which predicts the macrosomia, and you keep the postprandial blood glucose below 130. If it goes beyond that range, that will sensitize the fetal beta cell, and that will land up into complication, neonatal hyperglycemia, and all other things. That is, and lots of trials has been done, and basically before 2012 US FDA that makes the insulin into category C, which becomes the category B after 2012. So then it can be safely used in the pregnancy, and it is rightly told that whatever the therapy in pre-gestational diabetes in pregnancy, that is controlled blood sugar, that we should continue that. That is the notion, and that should be known to all, that don't change that therapy, because if changing the insulin therapy, that will end up into the controlled diabetes into the uncontrolled clinical situation. Thank you. It's
And another thing we must remember is that once this patient is treated for GDM, don't leave her, just follow her up, because this is the patient who's going to go into full-blown diabetes. So don't leave the therapy. Ask that patient to come again and again for repeat blood sugars.
Yes, sir. Absolutely. Absolutely.
And Dr. Sadhana Gupta, congratulate you for the excellent webinar that we have organized, and many more in the future as well.
Yes, sir.
I think two question answer is there from the audience.
Yes, sir. Yes, sir. I'll put up the questions.
Is there any HB?
Can I ask one question to Anuj, sir?
Dr. Anuj, it is a question for all, Anuj.
Yes, Dr. Sumit Sahu.
One question from my side. The traditional teaching is that if your sugars are not getting controlled by insulin, you may try adding on metformin. It is the other way around now. So when will you consider adding metformin to a patient being treated on insulin for GDM?
Yeah. Ideally, it is said that you can go for any dose of the insulin for correction of the glycemia. Okay. So there is no limit of the insulin higher, though there is no higher limit of the insulin uses. So you can use anything. But in certain conditions, the insulin resistance is very high. And we see that insulin dose is increasing very fast. Even every day, and even sometimes you can see that in a single day, morning and evening, the dose is increasing. These are the patients in which the metformin support is required, because so that we can slow down the increment speed of the insulin, and by doing so, patient may be having little easier, because it's very, very difficult to check the glucose every 3 times or 4 times in a day and increasing the insulin. So many times she cannot call the doctor, she cannot ask the doctor. So this is the best thing to there. At the same time, many times it is also seen that increased amount of the insulin also increases the weight of the mother, and it helps in increasing the weight of the mother. In such situation, if we see that maternal weight gain is more than the requirement, then metformin is the right choice to add with the insulin. Then that helps there.
Thank you, sir. Thank you for clarifying.
Thank you, sir. There are a few questions, sir, from Dr. Sumit Sahu. He said, is there any HbA1c range to start drug therapy or insulin therapy in GDM?
In gestational diabetes, HbA1c helps only for one thing, where it tells you whether your patient is carrying the diabetes before entering into the pregnancy or not. In our country, or in most of the countries, many of the times the pregnancies are not planned. So whenever we see the unplanned pregnancy, we don't know about the pre-gestational glucose level. So in such situation, HbA1c helps. There are certain studies which are coming up now, which says that HbA1c can help in the progression phase of the GDM also. But there are multiple if and ifs are there. And like in India, like country, the HbA1c standardization is not the same in all labs. Anemia is a big problem for the Indian subcontinent. In such situation, HbA1c sometimes may not be exactly relied upon. So that's why these are the things I always say that SMBG is the best thing to keep on doing glycemic correction instead of believing on the HbA1c. But we must get HbA1c done in the first trimester and also do it in the end of the pregnancy or in between pregnancy also to check whatever you are doing, it is going on well or not. HbA1c should always be kept less than 6.5 before entering into the pregnancy, and in the pregnancy it should be always less than 6.
One thing I would like to make clear, Dr. Anuj, that I think you will also echo that what I got from the question, that HbA1c is not a screening test for GDM. That is for sure.
Not a screening test for the GDM.
Question was that in
yes, I agree with you. It is not a screening test for the GDM. But one thing I could get that this is a test which tell you that your patient needs insulin or not.
Yes.
Suppose if HbA1c is very high, it means you must start the patient insulin immediately without waiting the results of the MNT for 2 weeks. Then you don't need to go for the 2 weeks MNT.
And in pregnancy, actually, rapid RBC turnover is also, again, it makes HbA1c a little like skeptical, we cannot say. So one question, acarbose, I think.
Acarbose. Acarbose, ma'am. Yes, sir.
So, Anuj, we don't know about it.
Acarbose.
Acarbose, we don't have sufficient amount of the data about acarbose. There has been few studies which has been done by our DIPSI team, and one of the gynecologists, I'm forgetting her name, she has done few studies, but the number of inclusions are not enough to make it into the guidelines. But theoretically, we can see and we can say that acarbose is a medicine which is not absorbed in the body. It is simply inhibiting the alpha glucosidase enzyme, which is responsible for the absorption of the carbohydrate. And being an alpha glucosidase inhibitor, does not allow the glucose to be absorbed in the body. But how much it causes harm or how much it is acceptable cannot be said at this point of the time, because in pregnancy we cannot say that all the glucose whatever the mother is eating that should be taken away from the alpha glucosidase inhibitors or with the fecal matter, because she is having a life inside of her, and for that life she needs continuous supply of the glucose also. So this is this has to be decided. Some more trials and some more studies maybe in the future for the whether alpha glucosidase inhibitors can be used safely in the pregnancy or not.
Thanks, sir, for the insight. And there was one more statement from Dr. Indira Gunturi that many people are doing random blood sugar. So is there any advantage or help, or can it be used or not, sir?
Random blood sugar for the diabetes or for the GDM? In GDM, if anybody is doing the random blood sugar, it will simply tell you that if it is more than 200 or it is more than 140, sorry, in the non-diabetic, it is more than 200, or it is diabetic women or GDM women, if it is more than 130 or 140, then it simply says that therapy is not appropriate. The treatment is not appropriate and is not enough. So this much only information will be getting by the random blood sugar. But if you want to regulate the insulin, if you want to make the treatment appropriate, if you want to regulate the dose of the insulin or dose of the OHA, whatever you are giving, then you need to check the fasting plasma glucose as well as postprandial glucose. That then only you can decide how much you to increase and how much up titration or down titration is needed.
Okay, sir. There is one question not in question answer chat box, that one patient, Dr. Ashmi, Patient was on metformin because of PCOS, so her blood sugar was okay, but in second trimester, around 24 weeks, blood sugar with metformin was 150. So at this moment, should they continue with metformin or add insulin or insulin with metformin? So that is
Yes.
the question.
She's already continuing with the metformin.
Yes. Yes.
So obviously, if she is not getting control and she has reached to the highest dose of the metformin, then she should add the insulin.
Actually, she says metformin was giving because of PCOS. So on first trimester, blood sugar was normal, and second trimester.
Let me tell you the concept behind the metformin. A pregnancy is the only condition. I many a times repeat it in multiple programs that pregnancy is the only condition in the life where insulin resistance is welcome. And this is for the formation of the fetus, so that the fetal formation can be very good, fetal formation can be achieved enough, which is required. But if it is going to the macrosomia, if it is increasing more than our requirement and more than requirement of the fetus, then this is the time to stop the insulin resistance. Then we should add the insulin, insulin sensitizer, or we should add the metformin kind of the thing, which can stop the insulin resistance there. But in the beginning, if we stop the insulin resistance, this will definitely jeopardize the growth of the fetus. So that's why principally metformin is not the right choice in the pregnancy, especially in the first part of the pregnancy. That's why you yourself said that after 20 weeks of the pregnancy, we should start that. So the reason behind this is that pregnancy, during the embryogenesis, during the formation of the body of the fetus, metformin should not come in between the growth of the child and the and after that we can continue with that just to stop the insulin resistance if it is increasing beyond our expectation and beyond our control. Then the
Thank you very much. I'm very happy about it because so many pushing of metformin in PCOS, and I'm very, very happy. Thank you, Dr. Anuj. I'm very, very good to listen these words. So I hope we can, any question asked, it was great to have, because, you know, as a physician, you will always bombard you with so many questions. So, thank you.
Status of glycosylated albumin. Is anybody using in any of the countries?
This should be used. This can be used. But problem is that in our country, the facilities are not available for that equally enough. But in the corporate hospital, glycated albumin can be used.
Thank you, sir. Very nice inputs by everyone. Thank you, Sadhna ma'am, for involving all of us.
And congratulations the team SAFOG as well as Dr. Sadhna Gupta for organizing such a wonderful program and including me, choosing me for this topic. I'm really grateful of you all. And thanks to my chairperson of my session, those who have given the wonderful comments, wonderful insight, and narrated the sessions. I'm really grateful to them also.
Congratulations.
Thank you, sir.
Thank you.
Any comment from any other dignitary on the dais, on the platform?
Sadhana, it was really wonderful. And we are eagerly looking forward to the second part, because management is really important. I think it's very, very useful, the basics and then the management. It was wonderful, ma'am. Thank you so much for having got such extreme.
Now I remember after looking Dr. Chitra, I could remember the Dr. Anjalakshi. She has done the study on the cargos. I just got.
Dr. Padam Rajpant, are you here, Dr. Padam Raj?
Here, ma'am.
So yeah, we will like your last comment.
Yeah. Thank you, ma'am. Thank you, Rakshadna, for managing all this CME, wonderful CME. Hope it should be beneficial for all of us. And thank you all the speakers, eminent speakers, and our today's panelists and our chairpersons, our SAFOG President, Secretary General of SAFOG. Thank you very much, and hope we'll continue these CMEs. As already Dr. Sadhna already told, we'll try to have one CME on non-communicable disease every month. We'll try our best and hope everybody will be benefited. Thank you, everyone. Thank you.
We have planned to do on every second Friday for LCD, and all the August audience who are with us, please give your suggestions for the topics like mental. I think next we will have GDM part 2, that is the antenatal fetal surveillance, maternal surveillance, postpartum care. Dr. Shyam Desai was very particular and very rightly, if we have to stop tsunami of GDM, then postpartum care. So please stay joining and keep enlarging the group who are having the special interest in NCD. So please, to me, to Padam Raj, from all SAFOG countries, give us the names who are really working and who are really interested in all type of NCD. So we and Dr. Padam Raj and the leadership, Dr. Shyam Desai, Dr. Ruhana, Dr. Rubina. So I think we will be able to do something substantial.
Thank you, everyone. Thank you.
Thank you.
So thank you all. And it's time to meet again on the second Friday next month. So I again acknowledge the presence of our President, SAFOG, Dr. Ruhana, and the General Secretary, Dr. Yusuf. Also the Chairperson, Dr. Padma Raj, and Co-Chair Sadhna Ma'am. And presence of the eminent speakers and chairpersons, Dr. Hema Divakar, Dr. Firdausi Begum, Dr. Sharmoon, Dr. Indu, Dr. Amita Pandey, Dr. Sandesh, Dr. Rubina, Dr. Chitra, Dr. Hira, also Dr. Anita Rajoria, Dr. Ashma Rana, Dr. Anuj Maheshwari, Shyam Desai sir, and Dr. Mriganka. I also thank all the delegates who make our efforts worthwhile. Otherwise, everything goes in vain. So, and also our patients whom we keep on, we learn from them, and then what we learn, we try to give them. So thank you, Shield Connect team. And we got a lot of key messages regarding screening, MNT, exercise, lifestyle, oral hypoglycemics, and insulin. So stay tuned, and we'll meet second Friday next month.
And thank you,
Thank you all.
Thank you, Amrita.
Thank you, ma'am.
We tried a different